Welcome to the first scientific session of day 3 of Pareeksha Anveshana 2021. Today we have with us Dr. H.B. Shashidhar, who is working as a professor, the Department of Pathology, Mysuru Medical College and Research Institute, Care Hospital, Mysuru. Sir has pursued MBBS graduation from JJ Medical College, Davangere, Kumbu University, 1998, and MD in subject of pathology from Mysuru Medical College and Research Institute, University of Health Science in 2007. Sir has done masters in business administration in healthcare management from Maharaja Institute of Professional Science, Mysuru, in 2014. Sir is having more than 20 years of clinical and academic expertise. Sir is having his expertise in different branches of pathology like neuropathology, oncopathology, blood banking, and transfusion medicine. Sir is currently working as an assistant professor in the Department of Pathology since 2017. Sir has started his career in 2000 as a lecturer in the Department of Pathology, Mysuru Medical College, Mysuru. Sir is also a guest faculty of pathology at several institutes like All India Institute of Speech and Hearing, Mysuru, Government Ayurveda Medical College, Mysuru, Government Naturopathy College, Mysuru. Sir has been teaching undergraduate MBBS students and paramedical students in various capacities for 15 years and postgraduate teacher since 2012. Sir is a recognized assessor of National Board of Examinations. Sir is an academic council member in Jayanti University of Health Sciences for the year 2021 to 2022. Sir was member in Faculty of Medicine in RGUHS from 2018 to 19. Sir was former technical advisor to St. Joseph Hospital Blood Bank, Mysuru. Sir is member secretary, Institutional Ethical Committee, Mysuru Medical College and Research Institute, Associated Hospital from 2014 till date. Sir has presented several papers in national and international forums. Sir has into his credit several articles in nationally and internationally recognized journals. Not only in these curricular aspects, Sir has also got a lot of credits in extracurricular aspects too. Sir was a university level hockey player in Kumbu University from 1995 to 96. And Sir was the NSS program officer of Mysuru Medical College and Research Institute for 6 years from 2008 to 2013. We are fortunate to have you here for today's scientific session, sir. In the name of JSS and Pareeksha Anveshana team, we wholeheartedly welcome you for today's session, sir. And we are eager to hear from you. Over to you, sir.
Thank you, Dr. Nabil, for that little bit, not that brief, but little bit elongated introduction of mine. Thank you so much. And at the same time, I would like to thank the organizers for giving me this opportunity to share what all knowledge I got with you people. We'll have a fruitful discussion. At the outset, I would like to give my humble pranams to His Holiness feet of Swamiji. And at the same time, I would like to give my salutations to my alma mater, Mysuru Medical College, without which I would not have been achieved anything in life. So thank you. I'll be sharing the screen and I'll be starting the session of this.
Yes, sir.
Is it been shared now, Madhusudan?
Yes, sir. Yes, sir. Visible.
Is it visible? Yeah.
Yes, sir.
Okay. You're seeing the first slide?
Yes, sir. Title slide, sir.
So good evening, everyone. Welcome to this session of understanding and interpretation of complete hemogram. This is my alma mater, Mysuru Medical College. So I'll be dealing with in this session, I'll be dealing my thing with these following contents. First, I'll be having a brief introduction. I'll be dealing with some of the parameters, hemoglobin parameters, very essential parameters, and the critical values involved in it. Very important that we identify critical values in each and every aspect of the investigations, because they're just like in LFT, RFT, even in hemogram also, we have a certain critical values which we should see first. So I'll be dealing with that. And at the same time, I'll be having this overview of RBC disorders, WBC disorders, and I'll be ending up with the platelet disorders, which we normally neglect in any of these complete hemograms. So starting from complete hemogram, it should start from a complete blood count. So we all I know that many of those prolific practitioners are there in this group. So you should be having that. Can go back to your I think while seeing patient, you'll be writing the investigations telling about either you'll be writing a CBC or complete hemogram. So there's a lot of difference involved in that. CBC has got a very limited information for you that just includes the counts, and particularly this everything will be done with those three-part analyzers, which I'll be dealing with that. Three-part analyzers, which will be given plain count, and some of those graphs, which are a little bit more confusing than convincing. And yeah, this is the one which I was talking about. If you give the CBC count, so this is the three-part analyzer which we use for the CBC. Of course, we got various other parameters involved in this complete hemogram, but we'll be giving you only the count, right? Count with what's WBC, lymphocyte count, and what's the platelet count. But you'll never be seeing this part of the investigation where we'll be having these graphs, the pictograms, and the parabolic graphs. This is the one which really gives us if the values give us 50%, the 50% is imparted by these graphs, which normally ignore. So that's why I would like to say at this juncture is, so this side lab should always have a technical person. So it's there's two difference between like a technician run lab and a technical person run lab. So where they'll always the technical people like pathologists or even the biochemist or microbiologist, they'll have some of the expertise where they can pick up some of the clues from these graphs. The things which we normally ignore are the one which gives us the most important information. So we'll be knowing the platelet count, normal platelet count, what is the RBC. We can interpret along with that. But what about these graphs? This gives us a very more information than the numbers. So this is the three-part analyzer which we normally use for these CBCs, and this is the five-part analyzer. So the complete hemogram, it involves a CBC. And earlier what we used to do, I remember my days of starting my profession where almost 21 years back, if you just going back to that scenario, it's really impossible to go back and think of those things where we used to give appointments for this complete hemograms. So just imagine around 12 to 15 appointments per day. That's it. So because we used to calculate each and everything, we used to have RBC count, we used to have hemoglobin and the hematocrit, and through which we used to calculate all these hemoglobin indices. And that used to be the most complicated thing. But we used to love it. That's different. But nowadays it's all ready made. Now we can do more than 1,000 hemograms per day without any hiccups. So that is the advancement of science which we are at today. At the same time, what we should make sure is we should use the technology to our thing. With those 5 parts, 6 part, and even 7 parts, we should not restrict ourselves only for the CBCs, only for the other things. Okay, so this is the one which I was talking about, where we had this 5-part analyzers, which gives us a complete picture about the flagging. Flagging is the one which says that there is some abnormality. If there is an abnormality, the machine itself, it's all artificial induced, artificial intelligence induced, where we'll be having those abnormalities which have been written here itself. Of course, there will be a question mark in front of that, which should be confirmed later by a peripheral smear. So this is where I want to put an onus that any CBC should be followed by a peripheral smear examination, and that is not only to confirm the findings of the CBC, at the same time, which also to go to a more extent, become an expertise in identifying the disease proper. Just by these are the one which says there is abnormality. This is a normal one, which of course the one which I focused earlier, this is a total abnormal one. But it never says you that there are macrocytes. It will never say what type of macrocytes are there, whether they're macrocytes or macrocytes. RBCs are decreased, it will never say, and even the RDW for that matter mildly increase. So it will never tell you about the morphology. It just says there is an increase in there is a change in morphology or dysmorphic RBCs are there, but it will never tell you what type of dysmorphic RBCs are there. So for that, a peripheral smear should be always should follow along with this. So whenever we get the complete hemogram, we should have a peripheral blood picture along with that. Very important. It becomes incomplete PB without peripheral blood smear. And this complete hemogram along with CBC, it also includes the reticulocyte count. So very important, the retic count is always included in this. So if at all, if you find any hemogram without reticulocyte count, so you please call back and tell that that's a part of that which I need it. Okay. So this is the one which is an extension of 5-part, which will tell you about the scattergrams. So this is what I told you about normal. Okay, I just don't want to go into detail about this intricacies. The graphs which you are seeing there these are normal. These all falls under normal category, depending on the granularity and the complexity of the WBCs involved. So this is the one, the neutrophil eosinophils. So this is an ideal location where we can see these. We want to locate these in the scattergram. We should locate this film, this picture. The granularity is not that complex, no deviation towards the right. The size is absolutely fine. So this is the normal thing which will tell you everything about it. And this is the one granularity, the monocyte and the basophil count. This has been placed in a normal location. So you should this doesn't come into picture when you get a report. Nobody will give you these pictures along with the report. Of course, if you insist, you may get the soft copies. But what I want is, whenever you are diagnosing or you are interpreting a complex disease, always insist upon these, and you make sure that you interpret all along with this, which I am going to tell you further. This is the one which I called a 6-part analyzer. So where it will give a little bit more things. And what is more included? This is of course the NRBCs and the reticulocyte count. So which is included, which is not at all there. 3-part analyzer in front of this becomes more primitive. Okay, so it's almost 3 or second or third generation what you call the hematological analyzers. So these are the scattergrams, the histograms, which you normally use it for interpretation. Without colors, this is not useful. I just wanted you to show what are the things as we are going advanced. What are the things we should be expecting? And one more thing, I want, if we can increase this, yes. So one more thing I want everybody to concentrate is, you will be getting the differential count, right? You will be getting the total count. But what I want is, you should insist on the laboratory to give us the absolute count. Very important, because if there's a leukopenia, the distribution is normal. We always we treat the leukopenia if it is around 3,000 for that matter. If the neutrophils are 70%, lymphocytes are 25%, it's always normal. So we'll not be taking that seriously. But you just imagine 25% to around 3,000, it's almost 600 or 500 lymphocyte absolute count, which is really critical for the patient. So we should always see the picture not on the differential count, but on the absolute values. Absolute values of the WBC is very important for these things. Yeah, so this is the one which I called a 6-part. So as and when the investment goes high, even the scientific thing goes high, everything, you'll be getting the higher versions, of course. So you'll be getting more important informations, including the immature granulocytes. So this is the immature granulocytes. Everything falls within the limit, of course. So more and more about leukemia, you can diagnose more about any immature, or if there is any blasts involved in that, we can always diagnose this through the CBC count itself. So now what this has made is, this has made the morphological diagnosis, the complexity or the toughness has reduced for us pathologists. So we can just see this, and we can always have something is there in our mind. See, what mind doesn't know, eyes can't see. So by once we see what is there, mind will know that there is some amount of immature granulosity. So let me see what is that immaturity. If you just see without any of these values, seeing that will take around 20 minutes, 30 minutes analyzing a peripheral smear. But with these inputs, we can always say, see, NRBC is totally 0, 0. So let us not concentrate on RBCs or hemoglobin at all. Let us concentrate on WBC. So that is the improvement, the advancement of science has brought into this hemogram interpretation. This is going further. There are some amounts of thing which even a technician can diagnose. You can always say whether there is any increased RBC agglutination, if there is any shift to left or atypical lymphocytes. Very important. See, this has got a particular standard. So once it surpasses that, you can always tell there is some atypical lymphocytes. So good for patients. Okay, good for the subjects. This is there. So where we can easily diagnose, readily diagnose these diseases very importantly, even the iron deficiency for that matter, without getting the iron studies, the ferritins, the TIBCs, without getting that we can suspect there's iron deficiency. What more we'll be expecting? And more importantly, the blasts or abnormal lymphocytes. So it just gives us the clue that there is some abnormality. And one more important thing which I want to stress at this stage is, let us not go on the WBC count. Okay, so WBC count, everybody says it's more than 50,000. Always think about leukemia reaction. If it is more than 1 lakh, think about leukemias. It's all gone. So nowadays, even we are seeing 4,000, 8,000 WBC count, we are seeing leukemia. So please don't go upon the counts for that matter. If count is within 11,000, it's totally normal, nothing like that. So it's all gone. It's become obsolete. That thinking has become obsolete. So there should be a proper morphological diagnosis for any complete hemogram to come to the final conclusion. And particularly these platelet clumps for that matter, if at all, if there is thrombocytopenia, there is something I'll be telling you about that in the last few slides, where how these giant platelets and platelet clumps can always give an abnormal platelet count. So platelet count will be totally normal. There will be abnormal clumps. So platelet count, if it is 2.5 lakhs, it will be showing it as 30,000. So that is the one which we should always be very careful in picking up the thrombocytopenias. See, it's all difference between the admission of the patient and sending him home, is it not? 2.5 lakhs is okay, but what about the machine is showing it as 25,000? So definitely it's a critical value. I just told you about those critical values. First and foremost is we should be thinking about that is the hemoglobin, then the platelet count, then the WBC count. Remaining all those things are all complementary to each other. So where it's all depending upon one another. But these three things you should always be wary before interpreting any of these things. If at all, if you get CBC, you first see these three critical values and then we can always go further. So many of the slides which I put, just wanted you to get more serious about this, because more of these things will be a little too complex to diagnose on a complete hemogram. But still, very easily you can diagnose these hemoglobinopathies, the parasitemias, the nutritional deficiencies for that matter, like iron deficiencies, vitamin B12 deficiencies. Very readily we can diagnose with those MCVs, the hematocrits, and the hemoglobin. That is enough to say whether it's a microcytic or a macrocytic, is it not? You don't need exactly a peripheral spear unless and until there is any associated disease. I'll be telling you about what was the associated disease later. And of course, we cannot have any other things like other than morphological diagnosis to rule out these hematopoietic malignancies. And of course, with the drugs, toxins, this is the one now we are seeing commonly, particularly the chemical-induced anemias, the drug-induced anemias. Nowadays, with the over-the-counter drugs, many of these people are coming with those aplastic anemia-like picture. Particularly this, they'll be not exactly going for bone marrow fibrosis, but unless and until this is recognized at the earliest, it becomes very difficult to manage the patients at the late stages. So very important that we should always pick up these things in complete hemogram. So we all know about these WBC parameters. As I told you, numbers are deceiving. So 11,000 or 4,500 doesn't mean that the person should not have any leukemia. So leukemias are white bloods. There are increased white blood. That was the basic definition given. But nowadays, the same word, the name is still there, but the concept has changed, where even the lesser count, 10,000, 15,000, we are seeing advanced stages of leukemia. That is most important in this case. The platelet parameters, of course, everybody knows about this. And The platelet count, we all know, the main MPVs. This is, of course, for the higher versions of these platelet disorders, like all those thrombocytopenic purpuras, and even those many like what are called abnormalities with those von Willebrand factor disease. Those things, this comes under. But for our discussion, let us not put into this. But there is one very important thing called as immature platelet fraction, which I'll be dealing at the last slide. Okay. So of course, this we don't get in 3-part or 5-part analyzers. We should be getting a higher version, and particularly in higher centers, we are having the 6-part analyzers and 7-part analyzers. We are getting this immature platelet fraction. Nowadays, I think for the last 3 or 4 years, this has come into picture. After this advent of this dengue. Dengue has become an endemic now. So we should be knowing about this immature platelet fracture. Why we need that, I'll be telling. So I'll be just going about a few salient features about RBCs. So RBC is the most neglected thing. We just diagnose it as leukemia and we start giving all those drugs for that one. But most important is we should be concentrating upon those morphological things. We should be concentrating on the numbers. What can go wrong with these RBCs? Okay. What more important is they don't have nucleus. So these are the end cells. Okay. So they don't have nucleus. They are the end cells. So we need to concentrate on the morphology of these RBCs. Particularly, as we all know, some basic about RBCs, the biconcavity is the one which gives us the central pallor, right? So central pallor should be 1/3, the remaining should be 2/3, and any increase or decrease we give it as hypochromia, and there's nothing called as hyperchromic. Okay, it's all purely theoretical. These are the RBC parameters. Each and everything is very important in this. Particularly, we will be using the red cell distribution bit. Everybody should know about that RDW. Once we are dealing with the anemias, we should be knowing about this RDW. Very important. As good as MCV, MCH, and MCHC is RDW. Okay, so I'll be telling why. So in newborns, of course, there are a few differences, and many of these labs which I've seen, they don't pick up these things. Hemoglobin, they give the same reference. So reference values are also very important. Just don't go upon the test values. We also see for the reference values, so which can always mislead anyone. So hematocrits, everything is increased, and of course, many times the MCV will be more than 103, 106. Just imagine the same thing in adults. This goes for macrocytes, but it's normal in newborns. So very important that we all look upon this, because many of those labs don't give that detailed investigation report. They'll be just giving us the CBC with all these categories of MCV, and which I've seen many times, like even there'll be no reference values as well. So why I'm telling is, just make sure that you pick those who have that standardness in them. We will run those quality checks. Quality checks are very important in any of the particular automation in hematology. That's a major thing nowadays. Now with the advent of NABL, very important that we look for those NABL or accredited or ISO accredited labs where they'll be running almost two, one in the start at the and another at the end of the session. These QCs, okay, unless the QCs match, they don't run at all, and they're not supposed to run with those NABL factor coming into being. So that gives us extra what called trust on them, trust on the investigations part, where we can say, yeah, this is it. Otherwise, if you're getting it from any other labs, we always think why the last thing which comes to our mind is why can't the lab go wrong? Okay, that should never come to our picture whenever we are interpreting this. So whenever we get, where you get this decreased RBCs, we never see for this RBC count, is it not? So we always ignore this RBC count. We just see for the hemoglobin and hematocrit, and we'll come to a conclusion. But you always should see the RBCs. So particularly in case of some scenarios, clinical scenarios like blood loss, whenever there's a trauma, surgery, of course, RBC count and hemoglobin go hand in hand. But there are some isolated events where there can always be a gross difference between them, which can lead us to a diagnosis. Okay, like impaired red cell production. So they are common in that. RBC destruction, they look the numbers are okay, but they look abnormal in this. this case. Okay, particularly the blood loss, acute blood loss and chronic blood loss makes a lot of changes in this. Particularly in acute blood loss, the hemoglobin remains the same, but RBCs are totally reduced. Very important to recognize that factor, what we called as normonormo-anemia. Okay, so nobody knows what knew earlier what is the normonormo-anemia. Everything looks normal, but the hemoglobin mass is reducing because of an acute blood loss. The bone marrow is still not come to that play. That's situation where it wants to change the morphology of the RBCs. Morphology of RBC is still the same in the peripheral picture, but there is constant. Many times I've seen the patients with the 2.53 hemoglobin with normo anemia. Okay, so very important that you see in that case the number of RBCs, and of course the one which we almost ignore, the hematocrit failures. What's the importance? We'll go further. So there is some features like decreased RBCs due to impaired production, this. Never think about rare things. Where our professors used to tell that if you think about rare things, you'll be rarely right. Okay, so you let us think about the common events which can lead on to decreased RBCs. Whenever there is a decreased proliferation or disturbance in proliferation and maturation, then let us think about the next complex things like myelodysplastic or myelopathic anemias, where the bone marrow itself is infiltrated by some foreign bodies or foreign material, where it has become incapable of producing the RBCs, okay, or even the other hematopoietic cells. So that's all the rare things, but still they can occur. That is important. And nowadays with the chronic inflammations, underlying chronic inflammations, anemia is the one thing which comes first. Okay, anemia, as it told, it's never a disease. It's just a symptomatology under which it's a what to call as umbrella under which many diseases get thing. Okay, so we can always diagnose them with this anemia. So chronic inflammation, anemia, they go hand in hand because of those erythropoietin getting inhibited by these chronic inflammatory cells. All those things come into picture in anemia or ACDs. Okay. Then the more complex than the previous slide, the pure red cell aplasias, the aplastic anemia. So these are all the things which in general practice, which is all like diagnosis by exclusion. But for a hematologist or for a pathologist, so this should be main criteria, particularly if you are dealing up, following it up with the peripheral smear, or even in case the most ultimate or the finest of the investigations which you can do for any hematological abnormality, that is bone marrow examination. Okay, so these things should be picked up, will be picked up in there, but still bone marrow doesn't come to complete pneumograph. Peripheral smear comes under, but this can lead on to that. Okay, if there is only if we suspect that there is something abnormality, we can go further. Okay, unless we suspect, we remain there. We just remain with those nutritional anemias, go on treating with that, and they never come. They never get treated. Okay, so particularly endocrine disorders, renal failure. Of course, this goes for super specialties. That is different, but still at our stage, we need to concentrate on these categories. We just should have in our mind where it has gone wrong. Okay, diagnosing the commonest thing is important. At the same time, thinking about the complex things is also same time important. So there is a disturbance of proliferation and maturation of erythroblasts. There can be pernicious anemia. It's usually most misdiagnosed, which is say, and folic acid intermediate deficiency. This is the one we should think about most commonly. Pernicious would be the last. Okay, so most common thinking about this reduced RBC productions. I'm not going to detail what happens in thalassemia, what happens in iron deficiency. I'll be just giving an overview of this complete hemogram. And then, of course, any decrease in RBCs or abnormal RBCs, there can be intrinsic abnormalities, extrinsic, mechanical trauma to red cells. Very important that we pick it up in peripheral smear, particularly those cystocytes, fragmented RBCs. Just more than 5% or 10% of these fragmented RBCs should always give us some hint about there is some amount of damage going on to these RBCs, either intravascular, extravascular, or even in spleen. Sometimes spleen just overfunctions, and then it stops overfunctioning. Okay, so there are many, almost 108 conditions where we call them as hypersplenism. So where is dysmorphic RBCs come into the peripheral smear, it just confuses you. So most important that we always follow it up. Okay, once we get any cystocyte or fragmented RBCs, it can be an isolated event of hypersplenism. We not take it that seriously. It should be repeated within 1 week or 48 hours to get it confirmed. And then we can always refer it to the higher centers. Okay, so that is very important in this stage. And infections, again, in endemic conditions, in endemic situations, we can have this malaria also inducing this hemolytic picture. There are various other complex diseases like spirochetes, elliptocytes. So as I told you, there is something called as RDW, okay, red cell distribution width, which always gives us a clue about the presence of these things, okay, particularly the apical hyperproteinemia. So it will not say that there is some amount of abnormal RBCs. It will say that this is the percentage of abnormal RBCs, okay. So then we can always follow it up with the peripheral smear. So many times in our picture, in our hospital, daily we will be dealing around 100, 110 CBCs, out of which around 40 to 50 turns into complete hemograms. Earlier we used to get around 300, 350 complete hemograms, but that's not necessary. Only once we pick up those abnormalities in the CBCs, then we can always follow it up with the complete hemogram or even the higher investigations, including peripheral smear. Okay, so many times there will be some amount of wastage of this manpower than the usage for these things. So just understanding a complete hemogram gives us a clear picture about how efficiently we can make use of this manpower. Okay, so here it is spirochetes, we'll be getting spirochetes, we'll be getting elliptocytes. So it all depends upon the percentage of the presence of those elliptocytes or spirochetes. Okay, spirochetes, even 1 or 2 is enough to say whether it is a hereditary spirocytosis. Even other hemolytic conditions also will be getting the spirochetes. And of course, the most sought after anemia, which is sickle cell anemia. Okay, everybody knows what is that mutation and all that, but we should be able to pick up those sickle cell in a peripheral smear. And for that, the clue which is we are getting is the RDW. Okay, reduced RBC, reduced hemoglobin, and of course, increased RDW. Okay, I'll be telling you about that RDW. There's a slide, I think. Yeah, these are the various abnormal, the conditions which can lead on to various abnormal RBCs, rather decreased RBC count as well. Where you can see high blood cell. We rarely see this high RBC count. Okay, so this almost goes along with those polycythemias, which we discuss later, again, when we have that increased hemoglobin levels and increased hematocrit. So everything goes almost 90-95% is a common thing, where there is something called as polycythemia, where all the 3 clonal population of cells are increased in the bone marrow. So basically, it's a clonal cell disorder. We got those hematopoietic stem cell. So that is where the abnormality in the polycythemia vera. There is something called as relative polycythemia or absolute polycythemia. It all depends upon how much is the dilution of the blood. If it is too much dehydrated, there is increased hematocrit. We call it as the relative polycythemia. If only the RBCs are increased in some of those conditions, we call it as absolute polycythemia. So there are certain conditions, just by seeing the red blood cell count, we can diagnose those things. Then comes to the hemoglobin part, most commonly discussed thing. So almost, as I told you, RBC hemoglobin goes hand in hand in 90%. I think there's almost common factor, except for those nutritional deficiencies. As I told you, yeah, this is one where polycythemia vera, high altitude, pulmonary. There is something called as in emphysema, COPDs and all that. So we'll be getting hemoglobin is increased. There's increased stress on that, and that will increase there's this erythropoietin stimulation on the bone marrow, giving out the increase in RBC count as well as hemoglobin. So it's all pseudo. It is not like patient is totally normal. Okay, it's not like if it is, there are some conditions like if it is decreased, it is abnormal. If it is normal or increased, it is normal. Hemoglobin doesn't fit into it. Even it is increased, also is abnormal. So there are so many things like dehydration, emphysema, macrocytosis. So where we should be diagnosing these conditions. And as I told you, there should be hemogram should always accompany with a reticulocyte. And but earlier we used to have this, particularly these RBCs. We pick up those ribosomal RNAs in that. Okay, they get precipitated in that, and we need those live RBCs. That's why we use the supravital dihydrase. Okay, so the normal peripheral smear which we use, they dry up, and those RBCs are killed, and then we are staining them with Leishman stain, right? But in this case, to pick up those RNA precipitates, we will be using those supravital stains, and this is the normal 0.5 to 1.5. Even it can be extended till 2% as well. This should be normal. Reduction than this, less than 0.5 also, will say that there is very less amount of capacity to the bone marrow to produce these RBCs. Even more than 1.5, there is a stress on that. That can be conditions like hemolytic anemias or any of those blood pictures, hyperproliferative blood pictures. Okay? So it must be adjusted. This is one which we do whenever there is an anemia which is not responding to any type of treatment. Okay, these things like reticulocyte index, that comes into picture at that scenario. But for all practical purposes, this is enough. Reticulocyte count, plain reticulocyte count is enough. So where will be getting increase? I told you hemolytic anemias, and whenever there is a response, very important that once you put them on treatment, but just because hemoglobin becomes normal, that should not be the end of that. It should always be followed up with an again a retic count, which should show that there is an increase in reticulocyte count. It's a process, transient process is going on where it is coming to the normal range. Okay, so in a recent hemorrhage also, the stress thalassemias and many of those leukemias and hypoxias, the pathologic conditions, which can always cause us increased retic count. But most importantly, in our scenario, response to treatment should be the ideal one where we can do. If at all, if there is any decreased retic count, so follow it up with reticulocyte count. Just transient increase in that should say that, yeah, there was arrest in that RBC maturation, and now it is becoming normal. Where it is decreased, there are certain conditions which are pathological conditions which it is decreased, like hormonal imbalance, the aplastic anemias, the cirrhosis, and again, most importantly, the anemia of chronic diseases. It's just part about PCV. Why I want to focus on this, earlier we used to have this Wintop's tube, where we used to always look upon the Buffy code. Now that we have the WBC count readily in hand, we don't need to see that. But many times, whenever we don't have the bone marrow picture, where the patient is totally ill, we can't do the bone marrow. Many times we'll be getting this Buffy code. Buffy code is the one which is a concentrate of these WBCs and a part of platelets as well. Okay, if you remember those components of blood banking, these are the one: plasma, the RBC, the packed cells. This is one which we give for the anemia, right? But Buffy code is the one which used to take up just that one drop of that Buffy code. We used to do that smear. It's almost say that it almost resembles 50% of bone marrow things, like what is going on under this thing. It can be always picked up in that Buffy code. Okay, so many times there was an earlier we used to use that thing called as subleukemia. It's like total count is totally total leukopenia, and many times no blasts at all in the peripheral smear. But they used to see that in bone marrow. We used to call it as aleukemic leukemia. Means it's the leukemic cells are not in the peripheral blood, but they are in the bone marrow. Subleukemic means it is not exceeding 20%. It is less than 5%. In that case, we normally take up this Buffy code preparation and we do that, and we can easily pick up more cells. Okay, of course, Buffy code means WBC concentrates. Everywhere we will see WBCs. We can easily pick up those blast cells if at all it is there. So normal count hematocrit, as I told you, very important to pick up these C for this hematocrit value in a CBC or complete hemogram to rule out these dehydrations, diarrheas, polycythemia vera. Many times we ignore this hematocrit, saying that they can be relative. We take these burns and diarrhea or dehydration part very easily. We take this up. We should be wary about this. Whenever 1 in 1,000, 1 in 10,000 can land up with polycythemia vera. So early diagnosis is very important in them. Low hematocrit. So same thing, which is just did opposite about that. So where all anemias will have this low hematocrit, particularly with the low RBC, low hemoglobin levels, it's bound to happen. So this is the one which we used to do for quality checks. Okay, so many times we'll be seeing 100, 150 CBCs. So we'll never suddenly one thing comes to our mind, like what if the machine is giving wrong? Okay, so in that case we pick up randomly and we do this. Okay, and it should pick up. So hemoglobin into 3 should be the hematocrit plus or minus 3. RBC into 3 should be the hemoglobin. So this is the one which can be reassuring for us that, yeah, of course, the value what we are getting is normal. Particularly, this is true whenever we go for camps where more than 100, 150 patients will be doing at a single stretch. Very important that we should have this quality checks in between as well. That is for us, not for the practitioners. Same thing as I told you, high hematocrit, low hematocrit values. So ESR, this also comes a part of that complete hemogram. Very important, this is a non-specific measure. And of course, we can use it just like retic count for the progress of the treatment. Very important that, of course, there is increased ESR, you recognize inflammation, you start treating them. But that is not, should not be the end. You should follow it up with one more ESR estimation when you think there is a what called as you have reached a final end point where you can say that, of course, the patient is recovering. So that should always be one thing which can confirm that, which can be again reassuring to you, is in the ESR estimation. Very important, as they tell just a basic thing about this ESR. It's a fibrinogen is the one which acts as an acute phase reactant, where in inflammatory conditions it increases. So the RBCs will stick to one another because of fibrinogen. Whenever there is increased inflammation, they stick faster. So more they settle down, more is the ESR. So, okay, it's not like the higher the count, lower the count. The more it settles down, more is the ESR, and that should tell us the prognosis of the inflammation, whichever it is there behind. So this is the pictorial. Of these neon codons, it has come up with the unique thing, CBCs along with ESR. Okay, so both of them can be seen in the same thing, where CBCs along with ESR, but we don't know how reliable they are. But best thing is particularly the acute, the chronic inflammations underlying that one, particularly the tuberculosis in our setup, very important, HIV and tuberculosis, and many other, particularly if there's gynecologist, pelvic inflammatory disorders, okay, SLEs, all those autoimmune conditions. There is always an increased lymphomas, all proliferate down as a
Shashidhar sir? Sorry, there is a small network issue. Sir will join back. Shashidhar sir?
Madhusudan, yeah, there was some connection.
Hi, sir. I thought so. Okay, sir. Dear participants, there is a small network issue. Sir will be right back. Please hold back.
ಆಗಿದೆನಾ? ಇವಾಗ ಆಗಿದೆ.
You're audible, sir.
Yeah, Masudan, it's there? No? Yeah, I'll just share the
Yes,
screen.
sir.
There's some problem in that? Share ಆಗ್ತಾ yes? ಏನು?
ಇಲ್ಲ ಸರ್, ಈಗ ಶೇರ್ ಮಾಡು.
Yeah, I'll do it.
Yes, sir.
ಇವಾಗ
Yes, sir.
ಬರ್ತಾ ಇದೆಯಾ?
Yes, sir. Sir, visible. Visible, sir.
Yeah. Share screen ಆಗ್ತಾ ಇದೆಯಲ್ಲ?
Yes, sir.
Yeah. Where we I think we lost in between. Not only we lost the connectivity, we also lost this. Yeah,
Calculation in yes, sir.
calculation of MCV. It's been there. Okay, yeah. So I was just talking about those indices, hemoglobin indices. Now it's all ready made. So because just by seeing the indices, many times you can always diagnose, particularly the most common variety about this anemia, particularly the iron deficiency anemias, the thalassemia, sideroblastic. Most common about this is anemia of chronic disease. So high MCV, low MCVs, most common anemias to be diagnosed with that. And MCH, MCHC, they're always complementary to each other. Except for that MCHC, there's one thing where we can always diagnose the hereditary spherocytosis, because practically it is impossible to say that the hemoglobin is more than what is there in the RBC thing. Just because the RBC is losing its membrane, so hemoglobin, there's a pseudo increase in hemoglobin level. So that is what called as increased MCHC. So hyperchromic, theoretically, it is seen only in hereditary spherocytosis, but not anywhere else. Okay. So this is one. So calculation, I'll just skip this. And this is one RDW, which I just want always. So how to think about this RDW? Just imagine about all these identical twins sitting in a room. So looking everybody looks the same. So it means the RDW, the redistribution width is normal. Okay, so it is normal value 11.5 to 14.5. And then just go on the stretching your imagination that you are taking out around 5 identical twins, and instead of them, you are randomly you are selecting some other people and making them sit inside. So there is some abnormality in that the distribution width or the similarity is gone, right? So that is what we call it as increased red cell distribution. So it's, and once you have this severe degree of RW increase, means nobody is identical, everybody is a random person you're seeing. So it just says that what is the amount of difference of dysmorphic RBCs you're seeing in a peripheral smear. Okay, so that is what is denoted by this red cell distribution rate. So this is one. This is more confusing. So where you'll be seeing high RWs, so you'll be seeing in blood transfusions, iron deficiency. It just tells you what is the difference in size, what's called as anisocytosis. So more the size changes in size, more is the RDW. So that is when you can always pick up those diseases like particularly in severe RDW, more than 28, 30, you will be getting in many of these hemolytic anemias. Very important that we pick up those RDWs in that. So a very important aspect of hemogram in this. This is one which I don't want. Yeah, this is what called as poikilocytes. See, this anisocytosis is the change in size. The change in shapes are also very important, which again is given out by this reduction or decrease in MCVs, MCHCs, and as good as RDWs. So you'll be seeing various strips. So what is the main thing which we go all along with the CBCs? It's the peripheral smear where we pick up all these things: erythrocytes, poikilocytes, cystocytes. Okay, so they in many of those. If this is the normal this thing area under which this comes, so almost half of that fragmentations in sickle cells, the teardrops, each one denotes one each disease, which should, of course, chronic diseases. Just imagine about hemolytic anemias. You're picking up those hemolytic anemias with those fragmented RBCs. So that's as good as you are treating a patient. Okay, so you're making him normal. So that should be the ultimate criteria, where peripheral picture should give you a final diagnosis of what is, particularly stomatocytes, HBC, target cells. Target cells very important in case of thalassemias. Very important. Many a time, around 8 to 10 years, we never diagnose this thalassemias unless until we see a peripheral smear. Then we go back and do all those ancillary tests, and we'll end up diagnosing this thing. Till then, it will be just anemia of without any cause. Okay, just like fever, FUO, fever of unknown origin, there will be anemia of unknown origin. So ultimately, morphological diagnosis is the one which clinches us the diagnosis. 80 to 90% which will be clinched. These are the various anisocytosis. So where the RBCs, of course, this looks more interesting for us, not for the clinicians, I feel. So, but still, you should be knowing how they look. Okay, once we give you microhypoanemia, how it should be looking behind. Okay, so what is the thing which goes? We are all people who work behind the screen, right? So what happens behind the screen? This is what. So you'll be seeing RBCs with all those pallor, less than 1/3 pallor. This is a neutrophil, right? And these are the small specks of platelets. These are the platelets, what you're taking in between. And the macrocytes fully hemoglobinized cells. Macrocytes will be fully hemoglobinized. And what is that reference range? What we get? We can't just measure that by using ruler. Okay, in the peripheral smear, we take a standard small lymphocyte. That too, the nucleus of the small lymphocyte, because it is resistant to change. It never changes. Very rarely it changes. So we take a nucleus of a small lymphocyte, and then we compare that with the size of RBCs to say whether it's a microcyte, macrocyte, or a normocyte, as good as that. Okay, so there's target cells, just like shooting targets. So very classically, it gives us the diagnosis of thalassemias. It should be more than 70%, 80%. Otherwise, we'll be getting 5 to 10% or less than 5% target cells in many of these anemias. But that should not be the criteria to diagnose them as thalassemia. Okay, so we should be having more amount about that. Okay, many of the other conditions like in post-splenectomy, A beta lipoproteinemia, we will be getting these target cells. Cystocytes or split cells, what you call as fragmented RBCs, all those hemolytic anemias will be getting them. So there will be some amount of anemia. It will not be severe anemia, but still there will be anemia, which can be easily picked up in a peripheral smear. And we can always correct. Many times this will be, many correctable causes are there, particularly DICs. We can always reduce that inception agent. We can always reduce the G6PD deficiency. This is one where, because of the oxidative injury, so there will be, of course, there's got several gradings. So because of the, like we'll be eating, many of those people will have drugs, fava beans, those things, they precipitate this oxidative injury, and they start having this G6PD exacerbation. So we can always stop those inciting agents once we diagnose these conditions. Teardrop cells, as good as dacrocytes. So many times, most commonly seen in microhypoanemias. Okay, so less than 5%, 10%, it's insignificant. Once it becomes more, then we'll think about, oh yeah, there is something like thalassemia major, or even in case of like aplastic crisis, these RBCs will have these dysmorphic features, and we can always suspect. We can always predict some of those conditions with this, particularly with these teardrop cells, the spirocytes. Okay, spirocytes, classic in hereditary spirocytosis. Not only that, you can see the spirocytes. Okay, so spirocytes, they are normal RBCs with central pallor. This is the one which has lost its RBC membrane because of the deficiency of various pectin anchorins. So there will be loss, and they'll look like spears. So they're just called, they can't deform themselves. Thing is, these RBCs, particularly spleen is a wonderful organ to what we call as to just filter out these normal and abnormal RBCs. In splenic sinusoids, these RBCs need to flex themselves. Almost they need to flex themselves to 1/3 of its size and then go through those sinusoids. Only if they go, they are normal. Okay, but these spherocytes and other things, they are so most rigid one, so they just get stuck up in their sinusoids, and the WBCs or the histocytes which are waiting up beside those sinusoids, they'll be waiting to clear of these. They just pluck them, they destroy them. So that's how the older RBCs are destroyed. They become less deformable. But in this case, even a younger RBCs, they get deformed or they become inflexible and they get destroyed. That is what called as intravascular hemolysis, what happens in this case. So that can be easily picked up by these spirocytes and those cystocytes, everything. Burst cells, echinocytes, elliptocytes, various causes where you can see, particularly burst cells, which this I always want to concentrate on this, because around 5 to 10% of these will have this burst cell, because any of these inpatients they'll be having this infusion, okay, is it the fluid infusion, and many a times they'll be taking blood from the same limb, and because of that there is some dysmorphism occurring in the RBC. So we should always be careful to have this, and if at all, if we are mentioning, we can't say that pathologists can't say that there are burst cells because of the IV infusion. Okay, we'll be just telling there are burst cells. So it's the responsibility of the clinicians to correlate that whether the same thing, this burst cell is because of those artifactual, because of the induced or idiopathic thing, or the clinician induced, or if it is really pathological in this case. Okay. Bite cell, this is one which is I just told about G6PD. There will be oxidative damage to the hemoglobin. It will be precipitated over the surface of the membrane, RBC membrane. Once they get into this spleen, these splenic sinusoids will identify them and they pluck them. So this is called as bite, as good as you are biting an apple, and these things are coming out. Okay, so these are the one pathognomonic of G6PD. You will be seeing one or two. You will be seeing one or two, but more than that, more than 5%, 10% pathognomonic of G6PD deficiency. As I told you, these are all what you call as, you can always reduce the occurrence of this. Of course, the patient will be having disease. They'll be having disease all through their life, but you can always reduce the incidence, reduce the severity of the disease once we diagnose that in the peripheral. And acanthocytes, very important. Same thing with more amount of spikes. Okay, you can see same. What is the difference between burst cells and that? So the spikes are less in this case. It's an umbrella-like. Okay, but in this case the spikes are more. Okay, spheroidal shape with more spikes. That is called as acanthocytes, or the burst cells, what we call it as. Okay, and very important in case of post-splenectomy, this will occur. And some of those lead poisoning, the sickle cells, the sickling of that. Many times even one sickle cell is enough to predict or even think about a sickle cell anemia, which is later we got those ancillary tests like sickling test and electrophoresis, through which we can diagnose this. Okay, particularly with the use of the sodium metabisulfate, we can always induce that hypoxic environment and we can alter those RBCs and we can diagnose this sickle cell anemia. Hinge bodies, again same thing, the same hinge bodies are plucked up and cause bite cells. NRBCs. Normally, you should not see NRBCs in an adult smear. Okay, less than 1% is okay. If it's more than that, you should always be thinking about these increased stress on the bone marrow, the mega, all those nutritional hypoproliferative dysmorphic anemias. Polychromatophils, basophilic stippling and lead poisoning, Cabot rings. These are all various different morphologies, which you call as poikilocytes. Okay, different shapes is poikilocytes. Role formation, as you told, it's also seen in case of increased hematocrit. So increased hematocrit will give us a signal that there can be increased role formation. Increased role formation will give us a signal that there can be underlying conditions like multiple myeloma, okay, chronic infections, everything. This is the malaria. Malaria very important. Nowadays we got many tests like antibody test for these things, but you can never say whether it's a recent infection or old infection. So it's always better to have a smear examination. There is something called as QBC, okay, quantitative Buffy code, which can be done. But many of these pathologies we feel it's more of subjective origin. So better to get a peripheral smear and get it confirmed. Very important to say about various stages of malaria. White blood, I'll just go through. Oh, I'm seeing that I'm running out of time. So I'll be just going through the white blood cells. So low WBC count, there's nothing called as pseudoleukopenia. It's all like artifactual one. So morphologically, you should always see for the morphology of these cells. As I told you, it's not like increase number, which should give us the clue that there can be some leukemia. Numbers are never characterized. Okay, they can never predict any disease as such. So this is a normal WBCs. Everybody knows what is that. These are all the granulocytes and the agranulocytes, okay, the eosinophils. Again, a basophil, the basophils should be less. And this is one thing where basophils can predict a leukemia, where increased basophil count, many a times with leukemia, we'll be seeing like many of those chronic leukemias getting into acute leukemias, there will be alteration in the basophil count, okay? So you should always be wary of those things in this case. Lymphocytes, monocytes, and this is the one which I was talking about, those platelet aggregates. It can always be misleading where this type of aggregates or clumping, the machine will be picking it up as a single entity. Okay, so with the no more gap, so it will give a severe thrombocytopenia. So always make sure that you ask the laboratory people, did you confirm that by a smear? Whenever you get severe thrombocytopenia, always make sure that unless and until it's a they are using 6-part or 5-part analyzer. If they are using 3-part analyzer, you always ask for the laboratory to get it confirmed by the peripheral smear. That is the standard, okay, protocol nowadays because of the abnormal accumulation of these things. So shift to left, we'll be giving in our report like there is shift to left, shift to right. It's just it will signify that where there is any stress on that, where there is any inflammation. Okay, so severe shift to left and all that, that is when we always predict some leukemias. So we also give in our picture like toxic granulations, nothing like toxic things which are getting accumulated. Thing is, the immature cells are getting loaded in the circulation. So it just says that there is some stress, there is some inflammation. This is one which we normally see. See the background, there are RBCs, there are big cells. These are the blast cells which we should never miss in a peripheral smear. And these are the R bodies. This we normally see it in acute myeloid leukemias. So we can see those nucleoli, classic nucleoli, granular cytoplasm, R bodies, more than 3 nucleoli, big cells, and almost 3 or 4 amount of size of an RBC. Classically, diagnosing of acute myeloid leukemia. Hypersegmented neutrophils, you'll see the same thing in what you call as macrocytic anemia as well. So it's not a severe thing that we are seeing hypersegmented neutrophil, but we pathologists, we always will, in the description of peripheral smear, will tell there are few hypersegmented neutrophils. But that means the clinician should always have in your mind that the patient can be, if the hemoglobin is in around 10.511, you should be thinking that, yeah, the patient maybe is going for an impending vitamin B12 deficiency. So it should always get corrected at that stage itself. So many of those degeneration. This is one apoptotic bodies which you see in severe inflammations, where the nuclei gets fragmented. Okay, so nothing serious in that, except for that we should be stopping those any of those drugs inducing that. And now I'll come to last few slides of platelets. So we always know that platelet has got a limited lifespan, about 9 to 12 days. So it's very important that we should be having all those, knowing all those conditions which can increase and decrease this platelet count. Okay, so there are grade 1, 2, 3, 4. Very important to concentrate on the 3 and 4. Okay, less than 25,000, 50,000. That is when the real symptoms starts, like mucosal bleeding or any of those trivial injuries leading on to increased bleeding time. Okay, so that is when we should be thinking about it. And even many times in our setup, even many of those corporate setups, 25,000, 40,000, 50,000, they start platelet transfusion. But our experience, we should wait till 10,000. We can wait till 10,000 and then we can start the platelet transfusion. Various conditions, this latter rather confuses you than convincing those platelet productions. Everybody knows about that. Most common is those antibody immune mediated, and in our scenario it's dengue. Okay, is the infectious conditions which causes severe thrombocytopenia. And just want to repeat, thrombocytopenia, if you get in a 3-part in a normal lab, always ask them to get it confirmed by a peripheral smear. So this is how, yeah, this is one artificial pseudothrombocytopenias. Like there are some phenomenon like platelets, satellitism, cold agglutinin reaction. These are all one which is not that serious, but which looks serious. Okay, like if you get 25,000 or 10,000 platelet, but the normal platelet count is 2 lakhs. So of course it gives you alarm. Okay, is it not? So to stop that, you always you should have these things in mind through for pseudothrombocytopenia, particularly the giant platelets. Pathognomically, they are seen in Bernard Solid syndrome, ITPs, MDS, and all that. But these are all very rare conditions, rarest of rare. DIC, TTP, you can see, MDS, you can see, but Bernard Solid, 1 in 1 lakh. So you should have that in mind, but at the same time, you should be thinking about the artifactual reduction in platelet. So this is the base abnormality. It's not like you just look a small dot of platelet, but in a higher magnification, you always can quantify that. We can always see the dysmorphic platelets or any abnormalities in platelets. But now, with the advent of these higher versions of these analyzers, we can always pick up those IPF as well. What is that IPF? Immature platelet fraction. Okay, so any increase and decrease of this IPF can always predict whether the platelet the person has got the capacity to get his platelet count corrected. Okay, innate. You don't need, particularly in dengue, this IPF, immature platelet fraction, comes into picture. So where we should always have this in our mind. Earlier, any ITPs and all that, severe thrombocytopenias, bone marrow was the only thing which we should have, which we had in our mind. We used to see those megakaryocytes, whether it is there or not. If it is totally reduced, then we think about suddenly transferring the platelets. But now with the advent of IPF in a higher these cell counters, you can avoid those stressful bone marrow investigations. Okay, so just one thing which I want to point out at this stage, it's 1.1 to 6.1% with the mean range of 3.4 is the normal one. It's increased, particularly in IATPs and TTPs. Okay, all those purpuras where there is decreased platelet count, and most significant is they were found these following patients during treatment, they recovered. The IPF fraction fell because of that, and once it starts falling, we can always say that the patient is improving. Okay, if it is adequate, like if it is within 1.1 and 6.1%, if the patient is having 25,000 platelet count, if you're seeing that the platelet fraction is normal, so we can always extend the deadline of platelet transfusion. Okay, because platelet transfusion itself is just like as good as a organ transplantation. If you do even blood transfusion as well, you should never take it but you can always postpone that. Just allow 1 or 2 days to the patient. He'll recover with this immature platelet fraction. So best thing is you go for if there is any higher if you're diagnosing any of these things like dengue with reduced platelet count, if you're thinking about a platelet transfusion, you go for a higher version of this current or these cell counters where you can have these IPFs. So that is the one which can. So this is the one where you can easily diagnose. This is the normal platelet count, 2.27. Just see the difference between platelet count, reduced platelet thrombocytopenia. This is the immature platelet fraction. It's too much increased here. Okay, it's too much increase. So means there is very less possibility that patient will be recovering at this stage. So start if it goes less than 25,000, start platelet transfusion. So the same thing in this case. So early indicator of marrow recovery in post-chemotherapy stem transplant. That's an higher version, but most importantly, we can use in most common conditions of diseases causing thrombocytopenia as well. Okay. So this is the one where 1 point, the same thing which is depicted pictorially. So there's the strongest independent platelet count derived predictor of antiplatelet response. Okay, even in case of chemotherapy, and very easily available. Even in normal CBC values, you'll be getting in 6-part or 7-part cell counters, you'll be getting this. I'll be ending up this session with this slide. So I thank one and all for your continued presence on this in this session. Thank you, organizers. Thank you, my alma mater, and of the organizers. Yeah, Dr. Madhusudan, is there any questions like that, or I overshot the time? Yeah, Dr. Madhusudan.
Thank you, sir.
Yeah,
Yes, sir.
Madhusudan.
Yes, sir. Yes, sir.
Yeah, hope everything went smooth, and I entered my session.
So we have 2-3 questions, sir. Can we take up, sir?
Yeah, please. Yeah.
Sir, there is a question on burst cells. Is it only during azotemic conditions or high urea conditions, or even during liver failure can we see this burst cells?
Yeah, it's all combined thing. So normally we say it's in uremic conditions. There's a standard one which we call it as uremic conditions. It's not like confined to liver or uremic, but more often what we see here is it's an induced, like idiopathic or sometimes hospital induced, where we'll be taking up the blood from the same limb where we have infused the fluid, and 90% of the burst cells what we see, it's all like because of the faulty technique of this thing, collection. Okay, so but it is most commonly seen in uremia, and more of that burst cells with those acanthocyte like picture. You should always think about those neurologists. Many times this is the only condition where neurologists will be referring us the peripheral smear. Okay, they'll be asking us to see for the acanthocytes. Okay, because they'll be having those neurological symptoms. The patients, they'll ask us for the see for the acanthocytes. So many times we get confused. Why? Because there's always like called as A beta lipoproteinemia, those conditions with those neurological symptoms. Always be thinking. It's not confined to that. It can be with very varied pathologies involving that.
Sir, one personal question from my side.
Please,
Um,
please.
when we do a peripheral smear, at times we see small bubble-like structures within the RBCs, and we don't see it in every slide. We see it in few slides occasionally. Is it because of the faulty technique, or is it because of the faulty staining technique, or what?
Yeah, definitely. It can be anything. It is definitely a faulty technique only. So it can be many times it is the stains which are not proper. Thing is, all these stains for every week we need to filter those Leishman stain. Okay, so filter those Leishman stain, and we can get those. Many times we'll be getting those small dots, and we'll be always thinking what if even there'll be clear halo around it also. Then we'll be thinking, what if this is malaria, malaria or ring forms? Okay,
Nucleated
so
RBCs or something.
yeah, exactly. Even so, it's always normally any of those vacuolations is very, particularly those ear vacuolations, very rare. And normally we don't see it in any conditions as such. But we see that in like toxic vacuoles in case of WBCs, that is pathognomonic, particularly in shift to left and all that. We'll be seeing that. Okay, we can see that in WBCs, which is pathognomonic, not in RBCs, definitely. It's always faulty technique only in our case.
Thank you, sir. On with this, we come to the end of the question, sir. I wholeheartedly thank you for making your time and spending your valuable time with us and giving us a very detailed explanation of a very vast subject. And you have made us understand it really well. And I'm sure a lot of UG students are here, and I'm sure even the UG students have understood it quite a lot easily, because you are so simple in explaining things, sir. Thanks a lot from department, from the team Pareeksha Anveshana, from Department of Roganidana, as well as from the college, from all management and teaching staff. We wholeheartedly thank you for spending time with us, sir. I request
Thank you.
Principal sir to please give concluding address. Sir, please, sir.
Namaste, namaste, sir. Namaste. Sir, namaste. Madhusudan, it's not audible. Madhusudan?
Sir. Once again, it is not audible, sir. Sir, I'll change the settings, sir. 1 second, sir.
Sir has to repeat it again from start.
Sir, am I audible, sir?
Yeah. It's audible now. Yes.
Sir, from this end, Dr. Sarveshwar.
Sir, namaste, sir. Namaste.
Namaskar, sir.
Yes. Namaste. Yes, sir.
I was
Good
just
Sir, yes, sir. Yes, sir.
commenting that the college photos you have, the nice Mysuru Medical College photo you have put, no, sir. Okay. It is complimenting to you also, because it's a knowledge hub. What do we hear? My dean sir is here. Everybody, I think, agree of that. That we are also hearing regarding the, I think it is century long Mysuru Medical College, and you are taking the legacy forward, sir. Such a wonderful presentation, young and dynamic, knowledgeable session. We have studied this in the graduation period, and that time, not so detailed also. Again, we are reminding and remembering. The professor was teaching us in hematology. That's the, maybe 88 it was. 1988 you were taking these classes. We are listening to the professor. It was such a memorable day. And now we have also listened to your in-depth knowledge, sir. As a young and dynamic and well-wisher of this institution also, behalf of everybody, we wholeheartedly submit our gratitude and a lot of thanks to you, sir. With a short notice, I know that you are also have little health issues here in and around. Apart from that, you have taken such a enthusiastic today. This is auspicious program. I pray Rajendra Mahaswamiji that everything, these blessings to come to you, sir. You have
Thank
to
you, sir.
prosper.
Thank you.
To come.
Thank you, sir. Thank you. Thank you very much.
Thank you very much, sir. Once again, we have a department, we have a delegates. A lot of thanks to you. Over to Dr. Echuri, our Dr. Bose. Over to you, sir.
Thank you, sir. Sir, thank you very much. So in the short notice, you have accepted our invitation and enlightened us regarding the complete hemogram. So nearly, just now I checked the number of participants. It's more than 400 participants they have taken this session. It shows that it's really interesting, and also so many questions they have given, sir, for interactions. For the shortage of time, we are going to conduct one more session for this. Thank you very much from our institution, our Vidyapita, and also from team Pareeksha Anveshana 2021. Sir. Thank you very much. Thank you very much, sir.
Thank you, sir. Thank you for the opportunity, sir. So I just can't say no for anything about JSS institutions. Yeah,
Sure,
I am part of that.
So we also consider you are a part of us, our institution, and thank you.
For the delegates' purpose, yeah, it's open up now. I just want to have a information to all our delegates. The SARS better half is Madam Professor Deepa. She's also a dynamic madam in the knowledge department of Kaijikisha. She's also heading coordination of all these academic activities. She's the UG coordinator, and we call it is in other words, it's called as the next to principal to take over all the academic activities. This is the information for all our esteemed delegates. That's better half, Dr. Deepa C. Patil. Thank you very much.
Thank you, sir. Thank you. Thank you for the kind words. Thank you.
Kadak sir, namaste. Namaste, sir. Kindly unmute. Yes.
Namaskar.
Shall we start the program, sir? Thank you, sir. Namaste all. Good evening. I welcome you all to this valedictory program of a 3-day long journey of Pareeksha Anveshana 2021, a national webinar on diagnostic principles organized by the Department of PG Studies in Roganidana of Jssamc Medical College, Mysuru, which was organized in commemoration with the 106th Jayanti celebration of Jagadguru, Rajagurutilaka, Dr. Shri Shivaratri, Rajendra Mahaswamiji. Let's begin this program by invoking Lord's blessings, for which I invite Ms. Rashmi of second year. Rashmi, please.
Mahaganapatim manasa smaraami Mahaganapatim manasa smaraami Vasishtha Vamadeva Devantita Mahaganapatim Mahadeva Sutam Guru Guhanutam Mahadeva Sutam Guru Guhanutam Koti Prakasham Shantam Mahakavya Natakati Priyam Mahakavya Natakati Priyam Mushigavahana Modaka Priyam Mahaganapatim Manasa Smarami Vasishtha Vamadeva Devantita Mahaganapatim.
Thank you, Rashmi, for the soulful singing and a wonderful beginning. It's our duty to welcome all to this program, for which I request our beloved Dean, Dr. Rajesh Udpudi, sir. Sir, please.
Om Shri Shivaratri Sharanayama Namaha. Good evening to everyone. From the Department of Roganidana and Vikriti Vijnana, a mega event that is a webinar on diagnostic principles by title Pareeksha Anveshana was organized. And today we are coming to the valedictory program. On this occasion, I want to welcome our beloved Executive Secretary, Dr. C.G. Betsurmat, who is always backbone and support to do all activities of the JSS Ayurveda Mahavidyalaya. On behalf of principal, staff and students, I wholeheartedly welcome you, sir, for this August gathering. Welcome, sir. I welcome Director Medical Education, JSS Mahavidyapita, Shri Mahesh R., who is enthusiastic to reach the institute up to the global remarks. So he's always supporting for all the events. On behalf of principal, staff and students, I welcome you for this gathering, sir. Welcome, sir. Today, chief guest, Dr. Dinesh Katoch, Senior CMO, CGHS, Ministry of Family, Health and Family Welfare, New Delhi, who is a famous personality in the Ayush sector, who is leading the Ayush sector to the global norms. On behalf of management, college, principal and staff and students, I welcome you for this gathering, sir. Welcome, sir. For all these activity, the energetic force is none other than our beloved principal, Dr. Sarbeshwar Kar. I welcome you for this August gathering, sir. Welcome, sir. I welcome today's speaker, Dr. Shashidhar, who delivered a speech on understanding and interpretation of complete hemogram, which is need of hour. I welcome you, sir, for this gathering. I welcome all the speakers, faculty members of different colleges, PG scholars, research scholars, practitioners, and all students. Around 1100 delegates were registered and present for this mega event, and around 300 papers were submitted. Among those, after scrutinizing so many things with a peer review committee, we are eligible to give best paper to the 40 plus papers only. And from Pan India, around 20 plus colleges were observing all the events of our JSS Ayur family. So I welcome all of you for the support, encouragement to organize such events. I thank you and all.
Thank you, sir. It's time we hear the chief guest, for which I request Associate Professor of Department of Roganidana, Dr. Satish sir, to please introduce our chief guest, Dr. DC Katoch sir. Satish sir, please.
So pranams to His Holiness. So good evening, one and all. So today we have with us eminent chief guest, Dr. DC Katoch sir. So sir is joint advisor in the Department of Ayush, Ministry of Health and Family Welfare, where he is assigned with the responsibility of Ayush drug control matters, coordinating formulations of 12th 5-year plan for Ayush and dealing with the international cooperations issues in the area of traditional medicine. Sir started his professional career in April 1983 as Ayurveda teacher in one of the oldest Ayurveda colleges of India, and after 10 years joined the central government of health scheme. Then being specialized in Ayurvedic treatment of heart diseases, he continued his clinical work even after joining ministry. Sir was promoted to joint advisor in Ayurveda in a span of 14 years and thereafter deputed to WHO as national consultant in traditional medicine and homeopathy for 3 years to serve as a focal point for implementing WHO Government of India Corporation strategy. So during his tenure in WHO, Sir was responsible for planning, coordination, and technical evaluation of the collaborative programs being undertaken in WHO for traditional Indian medicine and homeopathy. Sir has about 29 years of professional experience in clinical, academic, policy planning, and technical advisory fronts related to Ayurveda in particular and traditional medicine in general. Sir has represented India in many international delegations and is a member of many technical committees and task forces set up by the central and state governments for policy and strategic decisions. His contributions for the cause of Ayurveda and traditional medicines are numerous, which include amendment of Indian Central Council Act for wasting powers with the central government for grant of permission to open new colleges and courses of study. Then also development of the reorientation training and CME program, introduction of safety monitoring system of Ayurveda medicines, creation of databases of Ayurveda and homeopathic publications, standard treatment guidelines, standardization of Ayush terminologies, and publication of traditional herbal remedies for primary health care brought out by WHO. Sir is an Ayurvedic postgraduate with a versatile and immensely productive professional career. So additionally, he is qualified in intellectual property of health, rights, and human rights. So we are very lucky to have with us, sir. So I request you to address the delegates. Over to you, sir. Again, heartily welcome, sir.
Thank you, Dr. Satish. First of all, all the office bearers of the college management, JS Medical College, Ayurveda Medical College, Mysuru, its management, the principal, Dr. Sarveshwarkar, all the faculty members, and all the participants here. First of all, thanks from my side that I have been given the opportunity to grace this occasion, the validity function of the 3 days program for this diagnostic principles, that is Pareeksha Anveshana. Friends, now the science of traditional medicine, I think this is the emerging science. Emerging science. From my experience while working in WHO, I can tell you that the future challenges of healthcare, the future challenges of medicine, I think those can be addressed from the solutions which are provided in the traditional medicine, whether it is Ayurveda, Siddha, Unani, homeopathy, or in other systematics, because the challenges are going to be immense. And recently you might have seen the challenge of COVID-19, the global challenge of COVID-19. I think there is no proven medicine for the COVID-19. Whatever solutions are coming, they are coming from the traditional medicine. In India, I think we have been very, very successful in combating the COVID-19 outbreak with the help of Ayurveda medicines or Ayush interventions, whether they are the primary prevention of the COVID-19 infection, or by giving some prophylactic measures, or by adopting certain immunity boosting measures, or by interventions, the clinical interventions in the form of certain decoctions or the medicines. And you might have heard that from the Ministry of Ayush, I was advisor in the Ministry of Ayush up to January 2021. And Dr. Satish could not reveal my complete introduction. Actually, I was working in the Ministry of Ayush since 2000. And I had been instrumental in making many policy guidelines, many technical documents. So what I feel that whatever is there in the traditional knowledge, that knowledge need to have the scientific evidence that is being applied to the people. The science is being applied. The traditional science, Ayurveda science, that is being applied to them. And today, for the last 3 days, you have been discussing the diagnostic techniques of Ayurveda, diagnostic principles of Ayurveda, whether it is Mutra Pariksha. I have seen the brochure of this program, that there was a lecture from Dr. Sickle, and similarly from other teachers, other experts of Ayurveda, and there was some integrated approach adopted. And today, the previous speaker, I think Dr. Shashidhar, he was from the medical college. Now, the point is the principles of diagnosis and the principles of treatment which are given in our system of medicine, that is Ayurveda, those need to be interdependent on each other, interdependent upon each other. Like when we say that, okay, Agni Bridhi or Agni Mandir. Now, I just give you one example. Like in case of Pandu, when we do the hemoglobin examination, or when we do the peripheral smear examination, we come to know that, okay, the hemoglobin content is less, or there might be microcytic anemia, or it could be megaloblastic anemia. So what does it mean in Ayurvedic perspective? What does it mean? That needs to be understood. That needs to be interpreted in that way. I am a clinician also. For the last 38 years after graduating from the Anand Ayurvedic College, Jalandhar, I have been doing practice. Even in the ministry, when I was posted in the ministry, I used to entertain patients. I used to do the clinical practice. I used to go to the hospital, central government hospital. I used to sit there for seeing patient once in a week. And even in the ministry, the patient used to come to me. Now, these diagnostic principles which are given in Ayurveda, like if you see the Vikriti, underlying Vikriti, when we say that, okay, this anemia or the Pandu, it could be because of Raktagni Vriddhi or Raktagni Mantya. There are two different things. These are two different things. So how to interpret them scientifically, or how to interpret them in the contemporary parameters, like in case of anemia, when we say that, okay, this is there is less hemoglobin, we say that, okay, if it is less than 12 gram percent, it means the patient is suffering from anemia. Now, in Ayurvedic perspective, when we say that Pandu is emerging from the disturbance or from the Rasa Pradushti. So what Rasa Pradushti means in the context of Pandu? In the context of Pandu, what Rasa Pradushti means? Right? So Rasa Pradushti in the context of Pandu, from Ayurvedic perspective, it means low iron reserve. Low iron reserve. The total iron content in the blood is less. And then if it is from the Sushruta perspective, then it could be because of the loss of blood. There might be a history of bleeding. Now, how it could be interpreted? And if you see the Harit Sanhita, Harit says that Pandu is Majjadushti Janya Vikara. So in that case, it means it is from the bone marrow. Something wrong is there in the bone marrow. Because of that, their hemopoiesis is disturbed. And if you see the cells and the peripheral smear examination, if we do the peripheral smear examination, blood smear examination, if the microcytes are there, so according to Ayurvedic principles, it means there is a Raktagni Vriddhi. But if the megaloblastic anemia is there, the erythrocytes, they are of the large size, it means there is Raktagni Mantya. These are the principles given in our system. And if the pigmentation is less, hemoglobin content is less, it means there is some Ranjan Karam Dushti. Now, how that Ranjan Karam Dushti could be interpreted in the scientific terms? I think the terms are already there. It is only to correlate them. So why I am saying so? Because if you see the traditional medicine strategy of the WHO, the growth and development and promotion of any system of medicine, it can only happen if the scientific approaches are adopted, if the scientific interventions are done, if the evidences are created, if the things are standardized and there are proper parameters for quality control. Now, we have this Mutra Pareeksha. I think on the first day, Dr. Esikar, I know him, he's a very good expert of Ayurveda, particularly in the area of this Nidan and Vikriti Vigyan. And he worked in a CCRS also, and now he's in BHU. He has done a lot of good work. So that work needs to be carried forward. I think it is the responsibility of all the scientific persons, all the teachers, all the faculty members, and the researchers, that whatever knowledge base about Vikriti Vigyan, about Nidan we have in our system, that needs to be compared and put equivalent to the parameters or to the interpretation which is there in the contemporary medical science, as we call it as a modern system of medicine, also called the allopathic system of medicine. Now, for the development of the system, as I told you, for any system, whether it is modern medical system or for traditional medical system, as I told you that the WHO has given a lot of impetus for the development of traditional medicine. Now, the three building blocks are very, very important. for the system. And I am saying so in the context of this diagnostic techniques of Ayurveda or the diagnostic principles of Ayurveda, that these needs to be developed further scientifically, and these should be standardized, and these should be evidence based. So what needs to be done? What needs to be done now in our colleges, in our college hospitals, or in the health facilities? I think we have the diagnostic facilities, we have the laboratories. So there, when we make the diagnosis on the basis of Nidan Panchak, and the materials are sent for investigations, so we need to compare the outcomes, those diagnostic outcomes, or the results in our language, as well as in the contemporary language, that is the contemporary medical language. So that needs to be understood. And I think once it is done, it will become very easy for the practitioners to make diagnosis and to initiate a proper treatment on the basis of that those diagnostic parameters or those outcomes. Friends, the traditional medicine, I think this has already gone global, particularly Ayurveda and yoga from India has gone global. And in the last 4 or 5 years, particularly after the inception of Ministry of Ayush, previously it was Department of Ayush, now it is a full-fledged Ministry of Ayush. Lot of focus, lot of impetus has been given for the development of and the growth of this traditional medicine, Ayush systems, or Ayurveda. So my message and my request to all of you is that do involve in scientific development of the systems in whatever departments you are working, whether in Nidan department, whether in anatomy department, Sharir Rachana, or in any clinical department. The scientific development is required, evidence-based knowledge enhancement that is required, and second thing is standardization. So when we say that okay, रक्ताग्नि मांद्या और रक्तकण जो है उसका size कम हो गया या बड़ा हो गया, so the range that has to be standardized. So standardization is very important, because without standardization we cannot impose the regulations, we cannot impose the quality control. So for quality assurance and quality control, the standards are important, and standards of the diagnostic parameters, diagnostic results, and the diagnostic the procedures, all these are required. This is very, very important. And the third is once that is done, or in part or in whole, if it is done, that has to be documented. That has to be documented. Scientific documentation is very, very important. I know that the people in our system, they are very poor in scientific writing. That is why if you see the scientific literature, the publications from traditional medicine and including Ayurveda, they are very, very less. They are very, very less, and very few journals are there where these articles are published. Good articles, they are published, having this high impact. So my appeal to all of you, and that engage in scientific works, in research and development, and my congratulations to the college management and to the principal, as well as all the faculty members of the college, that they have organized this program, very nicely organized program, very compact program, and the very focused approach was adopted in the last 3 days. And I think this the deliberations in the program might have been beneficial to the participants, and they will carry home some message, some lessons, and a lot of learning. And after this, when they go back, I think they will start doing something scientific for the promotion, for the development of Ayurveda. Thank you very much, and all the best. Thank you very much.
Sir, still, sir, from this end, from JS Ayurveda Medical College, Mysuru. We are audible, sir, to you?
Yes, audible.
Yes, sir. We could see that enthusiasm, what I have seen 15 years before. Such a profound knowledge you are having, and your words are always, always you stress upon for the scientific validation and its implementations. What a message you are giving to the young generation. You had been role model at ministry, and I have seen you as a policymaker, and your vision and mission has opened a window. You are as an advisor. So, in Bikramditya court, there are advisors. In Akbar court, there are advisors, and they are all noble advisors. So, having profound knowledge in the science and also interpreting, Chakrapani has interpreted Charak Samhita. Similarly, the way you have interpreted in the since many years to the ministry, it has reached to its peak, sir. Hope your hard work and your vision and mission definitely will be make a direction to 2030 healthcare integration. That is we hope from this end, sir. 2030, if there is a possibility that healthcare system is going to be integrated under the leadership of our Honorable PMG and the leadership of our present secretary, Honorable Vaidya Rajesh Kotajaji. So these are all the highway, the road you have prepared, sir, during a tenure as advisor to the ministry. We know very personally to you, and your contribution also that pharmacovigilance. You have taken a lot of what do you call it, the initiation to make materialize what is today realistic is pharmacovigilance, which is strengthening our science in globally. With these few words, sir, how we are, you will be missing you, sir, for the really the presentation awarding to our UG, PG and teachers. However, as a chief guest, I want to just a 30-second, I want to update you, sir. There are 44 colleges participated pan India. There are 11 states represented in this auspicious program, and there are more than 1,050 are participated as a delegates, and 310 papers are been submitted for this forum for presentation. In that, you have two things you have highlighted, sir. Dr. A.C. Koch, Toilabindu. Sir, UG students also, they have presented paper for Toilabindu. You can see the interest among the UG. That is this forum is working for that only, sir. To create the interest, to create the initiations. There are UG students also have presented for Toilabindu. And also, sir, for Nadi, we have made a sincere attempt to popularize and to preserve the science of our heritage. For that, Madam Nisa Manikantan, the senior most Nari Visheshagya from Art of Living, Bangalore. I think I can say next to Trigunaji. She's so much expertise in Nari. She was also delivered on the Nari, what do you call as the specialty and also its importance. For that, sir, we have 15 such papers in the Nari. Importance of Nari and its utility for diagnosis purpose. 15 papers also we received, and we are also felicitating today the best paper in the Naris also. And also Sanjeev Sharmaji in his inaugural and keynote address, such a beautiful message sir was giving, the director come Vice Chancellor of All India Institute Jaipur. So this is our theme to you, sir, for your humble submission. I invite you, we are on 25th year, we are entering now. Sincerely invite you on behalf of management and entire fraternity, please visit to this institution, sir, which is entering to the 25th year. With these few words, I once again submit your gratitude to you. Probably you may not be there because you have pre-scheduled already, and we have late for that. Dr. Sashida's class was very extensive, and it was in turn, it was very useful for the students and delegates. Thank you. Over to Dr. Madhusudan.
Thank you, Dr. Sarveshwar, and my congratulations to all the award winners. I think those who have presented the scientific papers, my congratulations to them, and I wish that if those work which they have done, that should be published in some good journals. And I will make it a point that whenever I am in Mysuru, I will visit the institute. Thank you very much. and see you again. Okay, thank you. Thank you, Dr. Satish. Thank you.
Thank you for wholeheartedly accepting our invitation and also making your time and explaining in detail about the small intricacies of Dushta Rakta and other aspects of Pareeksha, sir. Thank you, Katoch, sir, from all of us here. And we wholeheartedly welcome to kindly visit our institution and also enlighten all of us by your knowledge. It was a vast 3-day program which spanned almost 10 hours every day with a lot of paper presentations from PGs, faculty. A point to mention, a lot of undergraduate scholars also, including internees, had presented papers, and we had 600, 700 plus, nearing 1,000 registrations. I would now request the organizing secretary of Pareeksha Anveshana and the HOD, Department of PG Studies in Roganidana, Dr. Subhash Chandra Bose, sir, to kindly give us the report of Pareeksha Anveshana 2021. Sir, please.
Submitting my humble pronamas to His Holiness. Good evening to one and all. I'm going to place a brief report of 3 days Knowledge Festival Pareeksha Anveshana 2021. A national webinar on diagnostic principle was organized by Department of PG Studies in Roganidana, JSS Ayurveda Medical College, Mysuru, from 13th September to 15th September 2021. In commemoration of 106th Jayanti celebration of Jagadguru, Rajagurutilaka, Dr. Sri Shivaratri, Rajendra Mahaswamiji. More than 1,000 delegates were registered. 300 plus scientific papers were presented in the different scientific sessions. As a part of
Jnana Dasoha, 2 guest speeches from the luminaries, 5 guest lectures from the stalwarts of Ayurveda across the country from the renowned institutions. Inaugural program of the webinar was conducted on 13th September 2021 at 4 p.m. The program was started with invocation by Ms. Sumedha Bhatt, second year BMS students. The dignitaries and delegates were welcomed by Dr. Sarveshwar Sir, Principal, JSS Ayurveda Medical College, Mysuru. Bird view of the total webinar was presented by Dr. Shirshananda Sharma Sir, Professor, Head of the Department of our institution. Chief guest of the program, Professor Dr. Sanjeev Sharma Sir, Director cum Vice Chancellor, National Institute of Ayurveda, Jaipur, Rajasthan. Sir was introduced to the program and chaired by the session Dr. Rashmi Pooja, Assistant Professor, JSS Ayurveda Medical College, Mysuru. Sir, in his speech, Professor Dr. Sanjeev Sharma Sir, in his speech, is pointed out the thorough understanding of the classical concepts of various aspects of Pareeksha. So that is a Roga Pareeksha and Rogi Pareeksha, and contemporary perspectives. He throws a light on integration in collective understanding, implementation, and interpretation is the need of the hour for precise diagnosis and better mankind services. Sir is also remembered Suttur Mata and His Holiness the blessings, and appreciated the services rendered by the Suttur Mata and the institutions in the various fields to the mankind services. In the presidential address, Dr. Rajesh A. Udupudi, Dean Academics of JSS Ayurveda Medical College, and noted the ethical issues and also the judicious advice and applications of the various Pareekshas. So in the diagnosis of a disease. Vote of thanks are rendered by Dr. Subhash Chandra Bose, Professor, Head of the Professor and Head Department of PG Studies in Roganidana. Dr. Madhusudan, BG, Associate Professor, mastered the ceremony in the first day of the program. Scientific sessions were started with the guest speech by Dr. Nisha Manikantan, Director and Chief Consultant for Cancer and Diabetic Care, Sri Sri College of Ayurveda and Research Center and Hospital, Bengaluru. Dr. Neville V. Joseph, Assistant Professor, Department of PG Studies in Roganidana, was introduced the guest to the gathering and chaired the session. Madam Dr. Nisha Manikantan was briefed about the history of Nadi Pareeksha. It's a practical approach and practice. Practical approach and practice. Also, recent research updates about its practices with the demo. And the number of queries it has put forwarded by the participants. So the session was so live and wonderful. The madam was has given the speech on the Nadi Pareeksha. In the second session, Dr. A.C. Kar, Professor, ex-head of Department of Roganidana, Banaras Hindu University, Varanasi, Sir has narrated the a brief theoretical understanding of the Mutra Pariksha and detailed practical applications of Mutra Pariksha with special reference to Tailabindu Pariksha. So with a number of videos with the demos sir has explained. Guest was introduced to the gathering by Dr. Satish GI, Associate Professor, Department of PG Studies in Roganidana, JSS Ayurveda Medical College, and also chaired the session on this occasion. In the second day of the webinar, started with the guest speech by Dr. Bhaskar Rao. So one of the luminary, so in the field of Roganidana of the Ayurveda, so is working as an associate professor. So in the college, Sri Venkateshwara Ayurveda College, Tirupati, Andhra Pradesh. Sir talked on the precise clinical aspects of cardiovascular disorders and its the various diagnostic approach. So it may be in terms of ECG, echo, color Doppler study, and the different biomarkers in understanding so the various the pathology of the cardiovascular disorders. Sir was introduced to the guest on that occasion, Dr. Rashmi Pujar of our institution, assistant professor. In the second scientific session, the speech is given by Dr. Mukesh Edavalat. So, sir is currently working as an assistant professor in Vaidyaratnam PS Warrior Ayurveda College, Kottakkal, Kerala. So, in his speech, so sir has experienced a vast clinical experience of a commonly encountered clinic in the OPD level, clinically encountered investigation. So that is a LFT, lipid profile test. So sorry, liver function test. I'm sorry, liver function test profile, and it's a clinical perspectives. In its clinical perspectives is a vast clinical experience. So sir has reached to each Ayurvedic the practitioners. So in his speech, Dr. Neville Joseph introduced the guest and chaired the session in that the occasion. In the third day, the program was started with the guest speech by one of the eminent scholar. So in the contemporary science, and also one of the most, the leading, the oldest institution. So in India, so that's Mysuru Medical College Research Institute, Mysuru. So sir is a professor, Dr. Shashidhar HP. So he's working as a professor in the Department of Pathology. And also, so yes, as a given on the talk, so nationally and internationally in the different conferences, and as so especially in the topic of the hemogram. So sir has explained or elaborate his talk on understanding and interpretation of a complete hemogram. So the diseases related to the RBCs, the diseases related to WBC, diseases related to platelets, and its different aspects. So nearly more than 400 participants were so interrogated with the different the queries, the number of queries in that sessions. So it was so very live. The session that we have observed in that the scientific session. Dr. Neville Joseph introduced the guest to the gathering and chaired the session, that scientific session. In all the 3 days, the morning 10 a.m. to 3:30 p.m. in a different 20 different schedules parallelly, so we conducted the scientific paper presentations from the faculties, PhD scholars, PG scholars, UG, from UG's undergraduate students from across the country. So in Pareeksha Anveshana 2021, more than 1,050 delegates were registered from the different states. Nearly 11 states that represented the scientific session Pareeksha Anveshana 2021. Karnataka, Gujarat, Kerala, Tamil Nadu, Uttar Pradesh, Andhra Pradesh, Telangana, Odisha, Jammu, Maharashtra, and Rajasthan. 11 states. And also 44 colleges, 44 Ayurveda colleges have taken part in the scientific the sessions. 17 colleges from Karnataka, 13 colleges from Maharashtra, 5 colleges from Kerala. So they have the maximum colleges from these states. They have taken a participation in the scientific event. Nearly 310 papers, scientific papers, as presented. The young scholars, they have presented their research, the research work in that Pareeksha Anveshana. Faculties, in the faculty area, 155 the faculties of different colleges, they have taken the delegation and participation, active participation. PhD scholars, 60 PhD scholars, so they have taken participation. 250 the PG scholars, they have taken participation in the scientific session, and 600 undergraduate students, they have taken the participation, the registered active participation in the session. So the scientific Pareeksha Anveshana 2021. Coming to the subject wise, in the Shalya Tantra, related to the Roganidana, the 12 scientific papers were presented in the department of Shalya Tantra. 16 papers, scientific papers were presented related to the Roganidana from Shalakya Tantra. So they have, we have observed they are presented. From the department of Prasuti Tantra, there are the 14 scientific papers were presented in connection with the Roganidana or the diagnostic principles. 3 papers from the department of Kaumara, the speciality of Kaumara. So 3 papers in relation to the diagnostic principles. So it was presented. 10 papers, scientific papers from Rasayana and Vajikarna related with the diagnostic principle. So it is it was presented. The remaining the papers, nearly the 236 papers from the mother department, Roganidana and the Kaya Chikitsa. So it was presented. Nearly 310 papers were presented in the scientific session. In the third day, the program started with a guest lecture with Dr. Shashidhar sir. And it is followed by the valedictory program. So it was started at 5:30. In the valedictory program, the session was chaired by one of the eminent personality in the field of Ayurveda, Dr. D.C. Katocha sir, was chaired the session. The session was welcomed by the guest and gathering, was welcomed by our Dean, Dr. Rajesh A. Udupudi, so the Dean Academics, JSS Ayurveda Medical College. Dr. Satish J. sir, the Associate Professor of our institution, has introduced the guest to on that occasion of a valedictory, the program. The chief guest on this occasion, Dr. Dinesh Katoch sir. So he's a senior CM of CGHS Ayurveda, and also sir is a former advisor, joint advisor to the Ministry of Ayush. Department of Health and Family Welfare. With his the busy schedule, sir was hurried to move to attend some ministerial meeting related to our system. So with our request, so sir has chaired the session as a chief the resource person. So in that valedictory note, and also he highlighted the need of the integration with the Ayurvedic terminologies with that of a contemporary understanding. So with the advanced the technologies in establishing the clinical findings, there are the limitation in understanding. So the Ayurvedic the principles and the procedures to carry out by making use of the different the technologies, so that we can definitely establish, understand that the minimizing the deviations in the understanding the pathological the findings, and a precise diagnosis can it be possible. So in that angle, so this 3 days festival Pareeksha Anveshana, so it's a really with the a different concept that the institution is organizing. Sir has appreciated. So about the 3 days, the knowledge festival on the different aspects, diagnostic aspects of principle in the diagnosis of a disease, diagnostic principles in the diagnosing a disease. And also, sir graced the occasion for the success of the program. And also, he remembered the Sutturu Mata, and also appreciating the work which is carried out to the mankind or to the society. Now is out of 1,050 delegates, 310 scientific paper presentations. It's the time to announce the best the papers, the presenters. In each session, in the 20 different scientific sessions, we have selected the two presenters, best presenters, nearly the 40 the presenters in the different the capacity, faculties, PhD scholars, PG scholars, and the UG scholars. We're going to award them for the best presentations. So it is due. It is in the next in the moments. Our beloved principal, Dr. Sarveshkar sir, is going to announce and award the best paper presenters. So this is a brief a report of 3 days the knowledge festival of diagnostic principles Pareeksha Anveshana 2021. Thank you one and all. In this occasion, I would like to thank all the directly, indirectly who are supported to the success of this program. From His Holiness Mahaswamiji, and also from the management. I used to thank from my wholeheartedly. I used to thank our beloved principal and all the faculties, the head of the department, and the vibrant team of organizing team of Pareeksha Anveshana 2021. And also, I thank all the college, the faculties and the students, those who have taken part in this in the grand success of the knowledge feast of Pareeksha Anveshana 2021. Once again, I thank you. I thank one and all.
Thank you, Subhash sir, for a detailed description of what happened over the past 3 days. It's a very interesting and most awaited time, for which I am sure all the paper presenters and all the delegates have been waiting for which I request our beloved principal respected principal, Dr. Sarbeshwar Karsar, to announce the prize winners of more than 20 paper presentation sessions, which was scheduled across the 3 days. Sir, over to you, sir, please.
Namaste to all of you. And thank you very much for this beautiful evening, which we are submitting the gratitude to our Param Pujya Jagadguru Shivaratri Rajendra Mahaswamiji on his 106th Jayanti celebration. And really I'm privileged. Nange punya ittu adu tamge idalla tamdu safalata tamdu achievement tamge samarpan marake as a prasadam from the His Holiness. Surrendering to the present pontiff, to the lotus feet of present pontiff, Sri Shivaratri Deshikendra Mahaswamiji Sikkata Sutur, surrendering the lotus feet of Param Pujya Gurudev Sri Sri Ravi Shankar Ji, Art of Living Bangalore, and also surrendering to the lotus feet of Param Pujya Dharmadhikari Sri Virendra Hegde Ji, Dharmasthala, Karnataka, and all these Guru Paramparas of this great legacy of JSS Mahavidyapita, which goes back to 1060 years. I welcome once again all of you. Let me submit my gratitude to all these esteemed principals. We have 44 colleges and 11 states, representing from 11 states, pan-India. 3 days knowledge feast under the leadership of Professor Dr. Subhos Boshi and his team, vibrant team, Dr. Satish, Dr. Madhusudan, Dr. Neville, Dr. Rashmi Pujar. So they have made it really possible. 300 extensive papers, scientific paper of 300 magnitude. Please understand, my dear delegates, respected delegates. And you know that accumulating 300, it was a great task for us. And I congratulate Dr. Subhos Bose and their team. They made it possible. It was a question mark. In the beginning, it was a question mark to go with this number or no, I said, one word I said. So this is the submission of gratitude on his 106th Jayanti celebration. So let everybody to get the prasadam. And now we are delighted for that everybody has got prasadam. The things which I am going to share with a lot of pride and privilege, I say all the 300s are winner. All the 300 paper, those are presented here. I have taken the feedback from my respected HOD and their team. They're all winners. It is a high standard papers. We have categorically put into the UG, PGs, internees, faculties, and research scholars. And once again, also very fine-tuned work they have done in the department, putting into the other side. The Department of Salak Tantra, they are the best papers. Department of Salak Tantra, from that the best. So also in each department, they have scientifically the fine-tune but the best possible. Categorically, they have put out the report which I am going to share to you. I have already gone through. Before that, everybody I am congratulating. All the 300 paper presenters across India, wholeheartedly from the Department of Roganidana, from the Department of Ayurvedic Medical College, Mysuru, and all the management authorities. I am wholeheartedly congratulating you, thanking you from this holy dais that you have definitely cherished this moment of presenting the paper because it's an auspicious program. The colleges, principals, I have a humble submission, gratitude. Dr. Saudi from Kopals, SD Murpi, Professor Mamta Madam, Kelly Belgaum, Dr. Prashant Jadarji, Alvaz Mudibidri, Dr. Sajid Mangalseri, AMC, SSMC Haveri, Chandrasekharji, SDM Hassan, our mentor, Live Dhanantari of present era, Professor Prasanna Narishan Rao sir, BNMC Bijapur, close friend, Dr. Sanjay Kalimati. Every day we could see his enthusiasm in Ayurveda and taking further. Sickle College Ayurvedic Science and Research, Bengaluru. Yes, my colleague, best colleague, Professor Ganeshji, and I congratulate Ganeshji that Sickle, once again, the Sickle College has top in the top. You have top in the best paper presentations. You have top into the 6 numbers. It's coming up shortly. Before that, I submit my thanks and gratitude and congratulations note to you. Through you, let everybody to get. Ashwini Advait Medical College, Tumkur, Dr. Harishji, close friend, and Sri Veerabantes Ayurvedic Medical College, Ilkal, Professor Kesav Chandra Dasji, my mentor. Karnataka Ayurvedic Medical College, Mangalore, Professor Ravi Rao sir. Thank you for encouraging your students to participate in this program. Hubli, MM Hubli, Prasant sir, our mentor. JMC Mysuru, the most dynamic principal and visionary, Professor Gajana Hegedeji. GMC Bangalore, Professor Ahalya Madam. We are submitting once again gratitude. We have submitted gratitude to you in the Teachers' Day on the 6th of September as a best teachers. Thank you, Madam, once again for encouraging our youngsters. GMC Shimoga, Dr. Doramani sir, Jagadguru Medical College in Chal, Dr. Professor Mohan sir, and let us have a pan-India look. Government Ayurvedic College Trivandrum, Dr. Harikishan sir, Baidratam PS Warrior Kotakal, Dr. Jaidavan sir, Amrita School of Ayurveda Kollam, Dr. Ramesh sir, PNPS AMC Kasurgod, Dr. I. Asaragudi. Yes, I'm right. PNNS Ayurveda College Thrissur, Professor Esr Estimation, Sri Jayanti Saraswati Ayurvedic Medical College Chennai, the oldest city of urban city of India. Dr. Chittaranjanji, good friend of me. SB Ayurveda College Tirupati, Dr. Mural Krishnaji, such a dynamic person as a principal at Tirupati, Lord Venkateswara. Vidarbha Ayurvedic Medical College Amaravati, Dr. Sushilji, SMBT Ayurveda College Nashik, GMC Nagpur, Dr. Subhas Rao, GMC Nandad, Dr. Jaswant Patilji, CSMS Ayurveda Mahavidyalaya, Aurangabad, Dr. Srikant Desmukhji, SUNHT Ayurveda College, Ahmednagar, Dr. Bilas Ji, Dr. DY College of Ayurveda Pune, Dr. Gunapati Ji. Parul Institute of Ayurveda, Gujarat, Vadodara, Gujarat. Most respected mentor, Dr. Hemant Tosikanji. from this proud land of Karnataka. You are leading in across India and the level of Global Ayurveda Forum. Thank you, sir, for all your inspiration and encouragement for this program. National Institute of Ayurveda Jaipur, who was our chief guest too, Professor, Director, Vice Chancellor Sanjeev Sharma ji, Jammu Institute of Ayurveda and Research, Dr. Saratji, BHU Varanasi, Dean BP Singh sir. Few colleges also we could not able to find out the principal's name. However, our gratitude to all of you. With submission to the gratitude to the esteemed principals, let me take the privilege, what you call as the ponder, the 7 pages which is submitted by our respected HOD Subhas Bosi. I am sharing with you. Let us start it. Let us start it. This moment they are waiting for that. Yes, you are the best. You are the best, my dear colleagues, my dear friends, my dear brothers, sisters. You are the best. May I start with Madhusudanji? Over to you. Put the congratulation note. Dr. Marin Joss, 3rd year PG Kaichikisha, Karnataka Ayurvedic Medical College, Mangalore, the city of Port Blair. Congratulations to you and your principals. Dr. Abhishta Jain, 2nd PG Roganidana, Alwas Ayurveda Medical College, Mudbidri. What a campus it is. What a dedication our Mona Alwas is giving to the student mass. We are our gratitude to you, Sir Mona Alwaji. Dr. Aishwarya K, 1st PG Kaichikisha, PNN Ayurveda College, Cheruturti, Kerala. Congratulations to you. Dr. Sridevi BP, 1st PG Rasastra, KLE Ayurveda Medical College, Belgaum. Congratulations to you and your principal. Dr. Samdeep Kumar, 3rd PG Roganidana, Parul Institute of Ayurveda, Parul University, Gujarat. We are proud of you. You are directly from the university. Congratulations to you and your dean and principal. Dr. Abhijit Rai, UK, 1st PG Roganidana, Alwas. Once again, Alwas Ayurveda Medical College, Mudbidri. Dr. Amulya Murthy Aku, 1st PG Swasthavata, BM Konkanwadi Ayurveda Medical College, Belgaum. Dr. Kartik R. Nair, 2nd PG Roganidana, SDM College of Ayurveda Udupi. The place of Ayurveda, as we call it, Mocha and Medina, that's the Udupi. Congratulations to you and Madam Mamta. Dr. Parth Kumar, 2nd PG Samhita Department, Government Ayurveda Medical College, Mysuru. Very close to us, yet profound knowledge. The most ancient college of South India. And I congratulate the team leader, Dr. Shivaratri sir and Dr. Sate sir. From our team, lot of compliments and regards to you, sir. Dr. Sate and Dr. Shivaratri sir, leading the team and guiding them. Dr. Sarvesh Kaur R. Tiwari, PG Roganidana, Government Ayurvedic College, Nagpur, Maharashtra. Dr. Kavya Krishnan C, 2nd PG Roganidana, Alwas Ayurvedic Medical College, Mudbidri. Once again, this is the 3rd time, Mudbidri. Dr. Samantri Jyoti, 2nd PG Samhita Department. Once again, Government Ayurvedic Medical College, Mysuru. Congratulations to you and your team leader, your mentor, Dr. Shivaratri sir and Dr. Sate sir. Dr. Resma Ashok, 2nd PG Samhita Department. Once again, Government Ayurvedic Medical College, Mysuru. Hat-trick. It's hat-trick, sir. It is hat-trick. What a presentation. What a presence here. Sir, Shivaratri sir and Sate, you know, for your transferring the knowledge, and it is once again, many times it has been evident. It's once again evident today. There are 3 bright stars. They come as a best paper presenter. We are proud of you, sir. Dr. Kartik KV, 1st PG, Shalatantra, again, KLE Ayurvedic Medical College, Belgaum. Congratulations. Dr. Bolu Kishan, the name is Kishan, the work also as like Bolu Kishan. Baat karte karte ab Bhogan. 2nd PG Scholars, Shalatantra, CC College of Ayurvedic Science and Research, Bangalore. Dr. Bolu, Hearty congratulations to you. I know I was working with you at, you are the student at Sri. Wholehearted congratulations to Dr. Shweta and her team. Dr. Shweta, HOD Department of PG Studies in Salient Features. Madam, hearty congratulations to you. And Dr. Shweta, I remember you are the alumni of this college, Jssamc Ayurvedic Medical College, Mysuru. Double banana for you. From JSS, you are alumni, and right now your students with your guidance, reaching the best. Dr. Sandeep S, Salak Department of Salakya, CC College of IV Science and Research, Bangalore, final PG scholars, a man of sincerity and commitment. Dr. Sandeep, I know you personally for your hard work and fingertips like Dr. Madhusudan. He's here as a broadcasting minister. You are also in Sri, Dr. Sandeep. Not only Ayurveda knowledge, you have got fine-tuned work in the Microsoft. Congratulations to you. And heartiest congratulations to your guide, your mentor, your HOD of your department, Dr. Naveen, and your team. PG studies in the Salak Tantra, Sri College, I Science and Research. Heartiest congratulations to Dr. Naveen. And we are proud of you. Thank you, Dr. Naveen. Dr. Deepak P. Nath, second PG Salak Tantra once again. Dr. Naveen, second congratulations to you. Sri College, I Science and Research. Whatever department you are having in Kriya Kalpas, Dr. Naveen, it is one of the best department in India, as far as I know, and you are leading the team and guiding the students for next generation. And it's the rarest subject, Salak Tantra, to diagnose the patient and treat them, that you have guided, and they have come out as a scholarly here as a best paper presenter. Congratulations to Dr. Naveen, to you and your team. Dr. Sabna Rani, CK, first PG scholar, PNM Ayurvedic Medical College, Chertuti. Second time congratulations to this college, head of the institution. Dr. Maheshwari Danapa Godoru, PG scholar in Department of PTSR. Again, CC College of Science and Research. This is called as the Unity in Diversity. What a presentation. It is in Sala, it is in Salaka, it is in Prasudandra. Hats up to you. And I congratulate the HOD of the department, Professor Sabita Madam, and their team, CC College of Science and Research, Department of Prasudandra. Dr. Pallavi Ganesh Pujari, past PG Roganidana, SDM College of Ayurveda, Udupi. Congratulations to you. Dr. Krisika M, past PG Rasayan and Bajikona. Whoa, what a subject this is. Rasayan Bajikona, very unique subject. Lot of compliments to you. This is you representing from the KLE Ayurvedic Medical College, Belgaum. Congratulations to you and your principal Jadar sir. Dr. Krishna Kumari Chaudhuri Balavant Bai. Such a what you call as the name which goes to Pan India. Okay. The second page is Sostavata, Government Ayurvedic Medical College, Mysuru. Once again, congratulations to and the luminaries, the HOD, Dr. Venkat Krishnanji. Yes, sir. Sostavata Dr. Venkat Krishnanji. I'm right? Yes. Congratulations to you, sir, and your team. Dr. Panaga, first PG, Rasastra, SDM College of Ayurveda, Udupi. I already said that it is a Makkah for Ayurveda, Makkah and Medina, Udupi. Dr. Anupama, second PG Roganidana, Ayurveda Mahavidyalaya, Hubli. Congratulations to you and Principal Sir, Prasan Sir. Dr. Adarsh T, first PG Rasana Bajikana. Oh, what boss, sir? Rasana Bajikana also not left out in your conclave. Again, KLE Ayurvedic Medical College, Belgaum. This is all compliment and congratulations go to the mentor who has made it possible, our Srinivas Prasadji, for bringing the Rasayan Bajikana to the forefront, now which is leading National Commission for ISM, that is at Delhi. Sir, our gratitude to you, Srinivas sir. Dr. Tahamubin, first PG Kamavitya, as you said, sir, both sir, Kamavitya PGs also have been participated. Again, KLE Belgaum, congratulations to you. Dr. Kasturi Rangan, BS, first PG Rasastra, SDM College of Ayurveda, Udupi. Dr. Gitika Kane, first PG Panchakarma, Amrita School of Ayurveda, Kerala. Dr. Santa Kumar, internist. Oh, first internist has come to the picture. Hearty congratulations to you, SDM College of Ayurveda, Udupi. Dr. Bhumika S, first PG Rasastra, again Belgaon, Kelly Belgaon. Dr. Anjana Krishnan, first PG Swasthavata, Government Ayurveda Medical College, Mysuru. Congratulations to you and your mentor, Dr. Venkat Krishna. Dr. Manasa, first PG Kajikisha, again Belgaon, Kelly Belgaon. Congratulations to you and your head of the institution, Jadar sir. Dr. Arunima, second PG Roganidana, Banaras Indian University, Varanasi. The city for knowledge. Our salutation to you, our salutation to all the faculties of Banaras. When Banaras name comes, our head go down automatically. Thank you very much. And also I thanks to you. I also thanks Dr. Anukul Chandrakar, Professor, Department of Roganidana Bigana, such a beautiful presentation. And you are in the same department. No, you are in the department of, you are in the department of Roganidana. Convey my best wishes and regards to Dr. Esr. Thank you very much. Dr. Nityasri K, second PG Kaya Chikisa, Sickle again, Sickle College of Ayurveda Science Research. The new Mokan Madina of Ayurveda is coming off here at Sri. I congratulate wholeheartedly the PG studies, HOD PG studies in Department of Kajiksa, Dr. Gopal Krishnaji. Dr. Gopal Krishnaji and your team, we compliment and congratulate you from this JS Ayurveda Medical College, Mysuru. Dr. Radhika Gupta, third year PG in Department of Kajiksa, Jammu Institute of Ayurveda, Jammu and Kashmir. What Madhusudanji? Kashmir to Kanyakumari. You are not left. Sir, this goes to Dr. Madhusudan. This goes to Dr. Madhusudan. National level is something else. PM Modi says, what Kashmir are? What Kashmir are? Kashmir also been there in your presentation. We really congratulate you, Madam, Dr. Radhika Gupta. Lot of hearty congratulations from this end. We are in the south part. We are also one of the heritage city of India, that is in Mysuru. We congratulate you and also welcome you for getting a chance for any. We are bringing 25th of celebration. Lot of program is coming offline. We welcome you. If you get a chance here, please visit this organization and this campus. We welcome you. And I also have a sincere gratitude to your principal. Please convey it. Thank you. Dr. Sri Lakshmi, third year PG, Salakatantra, Sri College of Ayurveda Science Research. What a hat-trick. Again, Salatantra, Dr. Shweta Madam. It's a hat-trick for you. It's a hat-trick for you. I am really proud of you, Madam Shweta and your team. 3 scholars, you have guided them to top in the best paper presentation. And keep on going, Madam. Ayurveda will be taking they'll be taking the Ayurveda to the better height with your guidance and inspiration. Dr. Dibyajyoti Maharana. Dr. Dibyajyoti Maharana, second year PG in Panchagama department. Sri Viramantes Ayurvedic Medical College, Ilkal. You have a diversity, Dr. Dibyajyoti. We have spoken to our HOD, Dr. Subhas Bose. We have accumulated, I think, in Nadi. You have also present in the Nadi. We have accumulated 9 papers. There are 8 or 9 papers was there for Nadi. And our team on the leadership of Dr. Bose sir, we have decided, let us keep our heritage. Let us congratulate, let us encourage the new young generations. Those are really keeping this science preserved. And I know that you have undergone Nadi training at Sri College of Science Research under the guidance of Madam Nisha Manikandan and one more sir's name was I'm not remembering right now. I have again my gratitude to Dr. Madam Nisha Manikandan for guiding you at that moment of your undergraduation at Sri College. And yes, one more Nadi Bisheshega, I'm just not remembering his name right now. Also our submission gratitude to you. And special thanks to Professor Dr. K.C. Dasi, your principal, your mentor, and who is leading one of the best Ayurveda colleges at North Karnataka, and it is a leading institution. Our gratitude to your principal, Professor K.C. Dasji. And congratulate once again from the JSS family, because you are showing your talent in all the department. Prasutantra also you are there in the last webinar, which was convened for 3 days. You are there in the Charak Samhita, that is called Charak Prakashini, and you have come up once again with a diversity that's called Nari Pareeksha at this moment. Congratulations to you. Thank you once again. All the best for you. Jammu principal, Jammu College principal name, Principal Dr. Saradji. Sarada. Dr. Sarada, ji madam, from the family of JSS Ayurvedic Medical College, Mysuru, we congratulate you. We submit our, the gratitude to your good self. And please come to encourage. We are bringing another more than 20 programs coming up in the 25th celebration, more than 25 programs. Kindly, sincerely request you to encourage your students, PG or UG, to participate in this program. Coming back to the faculties, most respected faculties, and judged by the dean and other senior professors, to your paper goes to Dr. Kirtan MS, Associate Professor Roganidana. Again, KLE Belgaum. Congratulations to you, sir. Hearty congratulations to you. And also through you, I again sincerely pass a message across your faculties to participate in the coming programs, which is scheduled for 1 year. Dr. Susmita VS, SDM College, Ayurveda, Urpi, Assistant Professor, Department of Rasastra. Namaste to you. Dr. Yogesha Acharya, name itself is Acharya. We are calling, we donate it Sudha Acharya, Charak Acharya. You are itself is Acharya. That DNA is already been having the signal. SDM College of Ayurveda, Urpi, Associate Professor in the Department of Swasthavrata. Once again, congratulations to Dr. Yogesha Acharya. Dr. Shilpa K, Assistant Professor, Department of Kaichicha, NFI Ayurveda Medical College, Bangalore. It's a new coming college coming up. Our former principal and dean, yes, former principal and dean, Upadhyayji is with you, and we submit our gratitude and compliments for his hard work, for which this institution has come to the premier stage. Through you, please submit my gratitude. All of us, we submit our gratitude to Dr. Upadhyayji. Presently, probably, I don't know, maybe medical superintendent or dean of NFI Medical College, Bangalore. Convey our best regards. Dr. Shilpa K, Assistant Professor, Department of Kaichicha. Dr. Gururaj N, Assistant Professor of Salak Tantra. I really proud of that. I really proud of you because I am in the Department of Salak Tantra. So you have presented a paper in the category of faculty. Dr. Gururaj N, congratulate you, salute to you. And once again, it is the college which is coming up to the par excellence of the global level. New campus is coming up. You are representing from Sri Jagadguru, Govisideshwar Ayurveda Medical College, Kopal, under the captaincy of Dr. Saudi. Please convey my best regard and wishes to Dr. Saudi, and my pranams to the lotus feet of Jagadguru, Sri Jagadguru, Govisideshwar Mahaswamiji. As I understood last time I was there in the campus, Mahaswamiji said that you are bringing a beautiful campus which is going to the par excellence. As 15-acre or 30-acre campus is coming up in the name of Ayurveda. I think it is going to be a center of Nalanda and Takshashila days to come in Ayurveda. Congratulations to you, doctor. And also my congratulations to your HOD, Biraji, Birahiramarji, who is leading the team as a PhD guide and a PG guide at your Sri Jagadguru Gobi Siddheswara Ayurveda Medical College, Kopal. Convey my best wishes and regards. Coming back to the UG, I'll take the privilege. Yeah. Susma Jain, second BMS, Albaz Ayurveda Medical College, Muribidri. Keep going. Don't think that I said that because you are studying at UG level, but for your knowledge, I salute from here. Keep going. Knowledge is always saluted. Don't think that you are UG. Knowledge is not limited. Okay, keep going. Alvaz Ayurvedic Medical College, Mudbidri. I understood from the organizing our broadcasting minister, see Dr. Madhusudanji, there are 15, more than 20 students are participated in the UG level from Mudbidri. Yes, sir. Am I right? Please listen to the delegates. See, one college at UG level, more than 15 students are participated. This message should go to every college. Please participate. Winning, everybody has won. 300, all the participants, 300 participants have won. We are just bringing some names. Vijaya Chandra. Vijay Chandra. Mr. Vijay Chandra. Mrs. Mr. Vijay Chandra. Alvaz Ayurvedic Medical College, Mudibidri. Congratulations to you and your principal and your guide who has put a mentor for you. Dr. Ananya Karant. Again, second BMS, Alvaz Ayurveda Medical College, Mudibidri. There are 4 undergraduate. Best paper goes to Mudibidri. The 4th one I'm talking about right now, Mrs. Shaminas Taranum. Shaminas Taranum. Again, second BMS, Alvaz Ayurveda Medical College, Mudibidri. Mrs. Pritish Lalaji Sahare, second BMS, Ashwini Ayurveda Medical College, Tumkur. Congratulations to you and your principal, Professor Harishji. Mrs. Purnima KN, Government Ayurvedic Medical College, Bengaluru. You are studying at second BMS. Congratulations to you and your principal or your mentor. I have spoken Saminas Taranum. Once again, I'll speak. She is from Mudbidri Ayurvedic College. Please. Okay. All are missed. Fine. Dikshita HK, second BMS, Government Ayurvedic Medical College, Shimoga, the new college which is coming up as the Government Ayurvedic Medical College, Shimoga, the place of Lord Shiva. Congratulations to you, and I am praying Lord Shiva to bless you. Sandeep C, second BMS, Government Ayurvedic Medical College, Shimoga. Yes, congratulations to you, the winner. And Sahiti Pulari, Alvaz Ayurvedic Medical College, Mudibidri. So I think so. We have Krishnan. Okay. Krishnan Chaudhuri Balamandabhai. Sir, we have spoken already. Sir, his name was there. His name was there in Swastabhata. Anjana Krishnan, past PG Department, GMC Mysuru. Over. So we have completed. And once again, I said it. Yeah, enough. So also, I have been share with you the participant from the Pan India. Let me speak about our twinkle stars. Let me get the opportunity to speak about, to share the name of our twinkle stars. Yes, twinkle stars, double twinkle and single twinkle. PGs and UGs. Yes, or I can say that PGs are not the stars, they are the sun, and the UGs are the stars. Come up. Dr. Prithvi, first PG Shalatantra. Congratulations. Dr. Prithvi, first PG Shalatantra. Congratulations to also Dr. Professor PG Guide, Dr. Siddha Aradamar, and their team for guiding and succeeding in this program. Dr. Manasa D, first PG Roganidana. Congratulations to Dr. Subhash Bose and your team. Dr. Aparna Uni, third PG Roganidana. Congratulations, Dr. Aparna Uni, and your mentor and guide. Dr. Sindura MS, second PG Roganidana Department. Congratulations to you and team leader, Dr. Boss. Dr. Hitaisi, first PG Roganidana. Congratulations to you, Dr. Hitaisi. Keep it up. A lot of program is coming up. So get ready. Yeah. So now we are talking about the twinkle, twinkle, little star, how you are up above the world's sky. Oh, such a quote. Come up. Yes, first I salute the guides. Those are guided you. My salutation to all of them. UG, Yashaswini GP, congratulations to you. Yashaswini GP, congratulations to you. Spandana M, congratulations to you. Apurva RV, congratulations to you. Asmita V, congratulations to you. Sumant CA, heartiest congratulations to you. Rasmi MK, heartiest congratulations to you. Molvika MK, heartiest congratulations to you for succeeding, for participating and succeeding to get the best paper presentation at the usual level. Twinkle Star, you are going to definitely going to sign as a son to sign and to give you your knowledge to everybody. Days to come, you'll remember this day. Your name is been documented here in the auspicious program commemoration with 106th joint celebration of Dr. Sri Shivaratri Rajendra Mahaswamiji in his 106th joint celebration. This you cannot get more auspicious than this. Dear friends, I am really lucky and luckiest most because the three mantras which we are chanting every day here, the Akshadaswa, knowledge to everybody, and share the knowledge to everybody. For this Anveshana Pareeksha is there for you, 3 days webinar. And Aragadaswa, this knowledge is once again going to enrich your skill and knowledge in the healthcare system. Therefore, the second mantra of our Param Pujya is Aragadaswa. And third one, that is Annadaswa. Nobody should go empty stomach. Your knowledge definitely a boon for you to fill your stomach and to fill the stomach of others. Because if you are rich, if you are stabilized financially, you have a full stomach food to you, you can share to others. Therefore, this program is designed. This is the third program we have designed. And one more program is coming up, the Department of Swasthya, that is in the malnutrition week, malnutrition month is going on, International Malnutrition Eradication. In that we are being in the program. I request all of you, please enroll your name and actively participate. With these notes, I thank the team that are both under his leadership. Submission my gratitude to the lotus feet of Param Pujya Deshikandra Mahaswamiji and everybody. Thank you, making me proud.
Thank you, sir, for your never reducing enthusiasm, especially when you start announcing the prizes. I'm sure the students have cherished a lot the way you announced the prizes. It's time we convey the thanks to all who is responsible, which I can easily say a successful 3-day webinar, for which I request Assistant Professor of Department of Roganidana, Dr. Rashmi Madam, to please render vote of thanks on behalf of the college, on behalf of the department, and on behalf of team Pareeksha Anveshana. I request Rashmi Madam for the vote of thanks. Madam, please.
Sorry. Yes. Pranamas to His Holiness Mahaswamiji. Very good evening to one and all. Every beginning has an end. In the same way, we have come to an end of this Knowledge Fest Pareeksha Anveshana 2021 3 days national webinar on diagnostic principle. It is responsibility of my team, Pareeksha Anveshana, to thank each and everyone who is directly or indirectly a part of it. So I take this opportunity on behalf of my team. First and foremost, I would like to extend thanks to the management for giving us an opportunity to organize Pareeksha Anveshana 2021. I would like to thank Executive Secretary Dr. C.G. Betsurmat sir for his support. I like to thank today's chief guest, Dr. D.C. Katoch sir, who is a senior CMO, CGHS Minister of Ayush. I also thank today's guest speaker, Dr. Shashidhar sir, Professor, Department of Pathology, Mysuru Medical Institute. I also extend my heartfelt gratitude to Director Mr. Mahesh sir for his valuable guidance and support. Words fall short to express our thanks to a person who is the backbone of all this event, who has a phenomenal energy and always inspires us. It is none other than our beloved principal sir, that is Dr. Sarveshwar sir. I also thank our beloved Dean, Dr. Rajesh Uppudi sir, for his valuable guidance and support. I extend my thanks to HODs of all the department, faculties, that is teaching and non-teaching faculties of JSS Ayurveda Medical College. I also extend thanks to all the resource persons who were a part of this 3 days knowledge feast. I also thank all our chairperson who patiently sat and gave us a result at the end. I thank Shri Ravindra, CIO, JSS Academy and Higher Education Research Center for his technical support, and Dr. Sumukh. I also thank all the PG scholars of all the department, and a very special thanks to the Department of PG Studies in Rasashastra, Vaishajya Kalpana and Swastharita. I also thank all the UG students and interns. I thank all the faculty members, PhD scholars, PG scholars and UG and delegates from different states all over the world. I also thank the principal of all this institute who permitted them to participate in this webinar. Here comes, which our principal sir kept a pet name, that is Broadcasting Minister, Dr. Madhusudan, so and his team for the technical support. So Dr. Madhusudan, who is Associate Professor of Roganidana Department, Dr. Aditya, who is an Assistant Professor of Shalyatantra Department, Dr. Prakash, who is a PG Scholar of Roganidana Department. State Minister is Dr. Aditya, sir. Last but not the least, no event can take a shape without a hardworking team. It was an dedication and enthusiasm of our team and organizing secretary which made this event a huge success. So I would like to thank Dr. Subhash Chandra Bose sir, HOD, Professor and Organizing Secretary, Dr. Satish G.I., Associate Professor, Dr. Madhusudan, Associate Professor, Dr. Neville B. Joseph, Assistant Professor, and also our dedicated, heartfelt thanks to Department PGs who have worked day and night in success of this national webinar. So final year PG scholar Aparna Unni and second year PG scholar Dr. Ibina, Dr. Sindura, Dr. Shilpa, first year PG scholar Dr. Prakash, Dr. Hiteshini, Dr. Vaishnavi, Dr. Manasa, and Dr. Shrikant. So, and also Dr. Kavya, who is an first year Roganidana PG scholar. So thank you one and all for being a part of this national webinar. Thank you.
Thank you all.
Thank you, Rashmi Madam, for rendering the vote of thanks. Again, thank you all for making this program a grand success. I wish to see you all in the next national level webinar being organized by the Department of PG Studies in Swasthavrata on 17th of September, day after tomorrow, which is named as Santarpana 2021 on the eve of Malnutrition Week and Malnutrition Month. Thank you all. Namaste.